So I would just, before we start, I'm Dr. Avisha, Pediatric Orthopedic Consultant. And so with much ado, so if we get started, I'll just introduce our first speaker. So our first speaker is Dr. Shruti Bansal. She's our resident consultant ENT surgeon, and she has done fellowship in cochlear implantology. And recently, she and Dr. Karnik and their team have completed more than 100 cochlear implants, which is a great feat for our hospital and the department as well. So today she is going to be speaking on approach to ear discharge in children. So I'd like to just welcome, if you can share your screen. And also, Shruti, if you can unmute your voice.
Yeah. Hi. Can you hear me now?
Yes, we can.
Hello everyone. Good afternoon. I'm Dr. Shruti. So I'll be talking on approach to a child with ear discharge. First, I'd like to start with this case, for which we had received a call few months back. An 8-year-old child with a history of left-sided ear discharge and fever was admitted under the care of a general pediatrician. He had symptoms for 5 days and he was admitted for IV antibiotics. When I went to see the child was febrile. He had altered sensorium with facial paralysis of the left side. He had a typical foul smelling left sided ear discharge. On taking a detailed history from the parents told that the child had ear discharge ever since he was 1 year old, which was on and off, and they would take him to a local practitioner who would give him some antibiotics and some ear drops, and the discharge would subside. He, despite being recommended an ENT consult, never went for a actual ENT examination and continued on taking medicines on and off. When I cleared the discharge from the ear and did an otoscopic examination, there were cholesteatoma flakes in the posterior superior part of the tympanic membrane. We immediately ordered for imaging in the form of a HRCT temporal and MRI. And what we saw was a CT scan showing the entire middle ear cavity filled with a soft tissue, which was cholesteatoma flakes, which was also eroding the dural plate and probably the facial plate as well. All the ossicles were destroyed. And to the surprise, what we saw, what was correlating with this clinical finding was that there was an otogenic brain abscess. So this child actually required a urgent drainage of the abscess followed by a mastoidectomy. So why I'm mentioning about this case is that this is one of those cases wherein you very often see a child presenting with a ear discharge, which is typically foul smelling. These patients, they will intermittently get better with antibiotics or ear drops, because it will only take care of the superimposed infection and not the real cause, which is the cholesteatoma. So now let's see that why actually the ear discharge is more common in children. So coming to the anatomy of the ear first, typically the ear is divided into three parts: the outer ear, the middle ear, and the inner ear. The outer ear comprises of a pinna and the external auditory canal. Middle ear consists of an eardrum, which is also known as tympanic membrane, the middle ear cavity, which receives opening of the eustachian tube and posteriorly opens into the mastoid cavity, and inner ear, which comprises of the cochleovestibular system. So what happens is that why are ear infections more common in children? The first and the most important reason is that they are still developing their immunity. And because their immune system is relatively weaker, plus the natural tendency of a toddler or a baby or a child to explore the world is by touching and by licking, or trying to see what is the object, so they become more prone to various infections. Also they stay in a environment and in in a nursery where they share the common objects, and then the viruses or the bacteria are transmitted to them, and with the underlying weaker immune system they become more prone to the upper respiratory tract infection and hence the ear infections. Another anatomical reason that why it is more commonly seen in children is the eustachian tube. We'll discuss about this in detail that the eustachian tubes are much smaller and more horizontal in children, because of which not only the the drainage of the fluid from the middle ear cavity to the nasopharynx becomes difficult, but also it is an easier passage for the infections to ascend from the nasopharynx up into the middle ear cavity. So this picture shows what I was just talking. This is an infant and this is an adult. And if you see the eustachian tube is much smaller, it is much more horizontal. And also, what is important is that it is less angulated. So what happens is that the whatever infections happens in the nasal cavity or the nasopharynx or the oral cavity, which are very open to getting the infections, the infective organisms can easily ascend up this tube and can cause infection in the middle ear cavity. And because of the same reason, whatever the fluid that accumulates in this cavity, it becomes difficult for the fluid to get drained. This leads to stagnation of the fluid in the tympanic cavity, and which becomes prone to infection and hence the ear discharge. So this is just a table that shows that how the eustachian tube is different in infant and adult. This is what we have just spoken. There's a significant difference in the length of the tube, 18 mm versus 36 mm. The angulation of the tube is much less. It is just 10 degrees in infants and as compared to 45 degrees in adult. Another thing is the lumen is much more wider and it is more flaccid. So because of this, there is the tendency of the infections to reach is much more higher in infants as compared to adults. This is a picture which shows the opening of the eustachian tube on the either side. On our right side is the middle ear cavity, and it shows that the the eustachian tube opens in the anterior end of the middle ear cavity, and on the nasopharyngeal side you see here is the opening of the eustachian tube, which is lies in the back of the nasal cavity or the nasopharynx. So it is a very common passage for all the pathogens entering through the nose or mouth, and any infection or allergy in this area can block this ending of the tube, leading to all the sequel of events leading to middle ear infection. So what happens is that whenever a child gets cold or upper respiratory tract infection or sore throat, all the pathogens they travel from the nasopharynx to the middle ear via the eustachian tube. In the process of traveling there, they elicit an inflammatory response in the eustachian tube mucosa as well as middle ear mucosa. Because of this inflammatory response, there is increased mucoid production or increased fluid formation that happens, and this fluid tends to get accumulated in the middle ear space, and that too also because there is an edema of the eustachian tube also. And we know that any stagnant fluid becomes a culture medium for all the pathogens to grow, and it leads to ear infection. So initially the child may present only with a cold cough with the fullness of the ear, hearing impairment and just bulging or a pain in the ear. But as soon as the infection is not controlled, the eardrum bulges and perforates, and it starts flowing, resulting in acute suppurative otitis media. So this is how this another important thing about the entire thing is that children have tonsils and adenoids. So they are supposed to get enlarged in response to any allergic response or the infective response. But what happens that in a process of doing that, they themselves becomes a source of infection, a, and b, they also obstruct the normal passage of the air through the air, the nasal cavity and the tracheal column. Because of this, they obstruct the nasopharyngeal opening and also becomes an obstruction. Therefore they become a source of infection to the eustachian tube and the middle ear, and as well as they block the drainage of the middle ear fluid into the nasopharynx. So all these children, they develop middle ear infections mostly in situation which is secondary to the adenoid and tonsillar hypertrophy. So this is what happens is that when there is a blockage of the tube or swelling or mucus blocks in the eustachian tube, there are back pressure changes, there is a fluid which builds up in the middle ear cavity, there it causes bulging of the eardrum which is very painful, and it leads to hearing loss and fullness in the ear. And if this process is not taken care by the body's immune system or by the medicines, this tends to perforate the eardrum, and then the ear discharge starts. So this is a radiographic picture. We very commonly order a X-ray nasopharynx lateral view for the children. This is an hypertrophied adenoid which is blocking the posterior part of the nasal cavity or the nasopharynx, and also blocking the eustachian tube opening. And if you actually see the tracheal air column, and if you trace it back, you see that the nasopharyngeal lumen is obstructed to more than 50% in this case. So this leads to both obstruction as well as altered airflow through the nasopharyngeal pathway. Coming to the types of ear discharge can be a very routine thing like a wax, which may be a yellowish or a brownish fluid, which may be filling the external auditory canal. It can be in response to any infection. It can be pus. It can be mucus. In patients with trauma or in patients with chronic suppurative otitis media or granulation, it may be a blood stain discharge, and very rarely it can be a watery discharge in the form of either CSF or even saliva in patients with parotid fistulas. Depending upon the type of the ear discharge and their causes, so if the consistency or if the nature of the discharge is mucopurulent, it is usually in response to the acute infection of the middle ear or chronic infection of the middle ear known as acute suppurative otitis media or chronic suppurative otitis media. Serous discharge is typically seen when there is an eczema of the external auditory canal, which is known as eczematous otitis externa. So, one thing which you should know is that whenever the discharge is mucoid in nature, it means it is coming from the middle ear because there are no mucus glands in the external auditory canal. A blood tinged discharge is typically seen when the infection of the middle ear becomes chronic, or if there are granulations, or in trauma. Very rarely in cases of tumor, which is very rarely seen in children. What is important is typical foul smelling or a fishy odor, rotten fish odor, which is seen with the discharge. It is very characteristic of cholesteatoma, and these children definitely need a proper, thorough otoscopic examination because they become a candidate for surgery. A watery discharge, which is usually seen following a head trauma, is usually CSF, which is leaking from the inner ear into the external ear. Depending upon the associated symptom, if your ear discharge is associated with pain, it is indicative of some acute infection, which can be an infection of the external ear, which is known as acute otitis externa, or infection of the middle ear, which is ASOM. If it is associated with pruritus, pruritus is itching. Most commonly, it is fungal infection, which is known as otomycosis. However, in patients with chronic otitis externa or chronic otitis media, the ear discharge may be associated with the itching. Patients who have recurrent infections or a recurrent ear discharge, like in the case I mentioned earlier, is usually seen in patients with chronic suppurative otitis media. Rarely it can be seen in patients who suffer from eczema or psoriasis of the external auditory canal. So typically, what is important is to know a purulent or a mucopurulent discharge is seen in patients of ASOM, chronic suppurative otitis media. It may be because of a ruptured furuncle in the external auditory canal, or sometimes in children, which is very common, is an impacted foreign body. So when do you really need to worry? What kind of an ear discharge actually needs a thorough examination and an ENT reference? First thing is when the discharge is scanty. Because a scanty discharge is usually the result of a cholesteatoma flakes. So normally cholesteatoma is not an infective pathology. It is a bone destroying disease which may have a superimposed infection and result in an ear discharge. So a scanty foul smelling discharge is a very typical of an unsafe CSOM. A purulent discharge may indicate an acute infection or a chronic infection of the middle ear. Foul smelling or a fishy odoring discharge, which I already mentioned, is typical of cholesteatoma. Sometimes the discharge may be associated with excessive pain, which have discussed, maybe because of some furuncle or again related to a infection of the middle ear. Discharge associated with giddiness and headache may indicate that the child is developing intracranial or extracranial complications of the middle ear infections. So, definitely, these patients need a thorough examination and even the imaging studies. So, broadly, if we classify the ear discharge into the painless discharge and the painful discharge, any discharge which is painful, if it is associated with, if there is a history of head injury and the nature of the discharge is watery and painless, it is usually the CSF which is leaking out. If the discharge is scanty and is foul smelling, it means it is a cholesteatoma which is causing the discharge. However, if the discharge is painless and it is profuse and non foul smelling, it may be just a chronic infection of the middle ear followed by a perforation leading to a profuse discharge. Typically, a discharge of ASOM is the patient will have symptoms of pain, severe pain, and then suddenly he will start discharging and there will be a sense of a pain relief. It is a typical symptom of acute infection of the middle ear, which develops secondary to the otitis media or otitis middle ear effusions. Coming to the painful causes of the ear discharge, if it is associated with tragal tenderness, it means there is a furuncle in the ear or there is an otitis externa or edema of the external auditory canal. Sometimes the painful discharge may be because of the impacted wax or the wax granuloma, or sometimes if it is associated with itching, it is typically the fungal infection of the external auditory canal, also known as otomycosis. So, coming to the management of the ear discharge, how do we manage a child who presents with an ear discharge? First and foremost is that we need to establish the diagnosis or know what we are actually dealing with. So, very important part is to take a thorough history, which means first and foremost we see whether the discharge is unilateral or a bilateral discharge. What is the consistency of the discharge? Whether the discharge is acute onset or a chronically discharging ear or it is intermittent in nature. What is the nature of the discharge? Whether is a foul smelling or a non-foul smelling, whether it is a blood stained discharge or a non-blood stained discharge, whether it is associated with hearing loss, because that also gives you a considerable amount of information what you are dealing with. Third thing is whether the discharge increases during the episodes of upper respiratory tract infections. So all these salient points in the history will give us a fair information that what we are basically dealing with. Second and most important is to do the thorough ENT examination. So when we are dealing with a child of an ear discharge, it is not important only to do an ear examination. What is more important is also to do a nose and a thorough throat examination, because as I already discussed that most of the time the reason for the ear discharge is a pathology which is lying in the oral cavity, which is a tonsillar hypertrophy, or in the nasopharynx, which is an adenoid hypertrophy. So a child with a ear discharge first needs to treat the underlying pathology, which is the adenotonsillar hypertrophy. Third thing is then we go to getting an audiological testing done to confirm our diagnosis and imaging in the form of HRCT temporal, or in some cases even the MRI. Now what we do is also every patient of ear discharge we need to do an oral toileting, which means that whenever the ear is discharging you need to clean the discharge, because it will not only help you to examine the tympanic membrane and the external auditory canal properly, but it also helps the ear drops to reach the site of the pathology. So it is very important that the oral toileting is done. Third thing comes is that now we come to the treatment part. What is the treatment of the ear discharge? Treatment includes definitely the conservative treatment, which includes antibiotics, which can be topical antibiotics, oral antibiotics, or IV antibiotics. We also need to give some antihistaminics and decongestants to take care of the edema of the eustachian tube, which is secondary to the nasal pathology or the allergic response. There's definitely a role of anti-inflammatory when it is associated with pain. Coming to the surgical part of it, there are various surgical options depending upon what is the cause of the ear discharge. One is grome. In patients with perforation, we can plan a tympanoplasty. In patients with unsafe ear, we need to think about doing a mastoidectomy. So when actually should you treat a patient with an antibiotic? Not every patient of ear discharge will need an antibiotic. So there are some basic guidelines which we have laid down. One is that if the patient has a very severe symptoms, which means that your ear discharge is associated with a lot of pain, the child is febrile, if patient has perforation, or if patient has a bilateral disease, also if a patient is developing complication as a result of the infection in the middle ear, which means the child is having a mastoiditis, which can be diagnosed by pressing on the mastoid tip. If it is tender on pressing, you get a fair idea that a child is developing mastoiditis. Or if patient is developing other forms of intracranial or extracranial complication, definitely you need to start the child on an IV antibiotic. For children less than 2 year old, it is difficult for them to express what exactly is happening, and they will only cry with the ear discharge. So we can also start antibiotics in patients less than 2 year old. Definitely in patients who are deficient immunocompromised. Antibiotics are highly recommended when if infection occurs in a patient who is a recipient of a cochlear implant, and to protect the only hearing ear. Children who are older than 2 year old, or children who are who can actually tell what exactly the symptoms are, we can think of treating them symptomatically. However, if there is no improvement in their symptoms after 2 days of conservative treatment, we must think of considering starting them on antibiotics. So what antibiotic therapy to give? The recommended is to give an amoxicillin. It is important that we should give a good 10-day course of antibiotic. Normally we usually we give augmentin only, but it is recommended that start with amoxicillin first, and if there is no improvement in symptoms after 48 hours, then add amoxicillin with clavulanic acid. Coming to gromes, gromes are also known as ear tubes or the pressure equalizing tubes or the middle ear ventilation tube. So this is how a grome looks inserted in the tympanic membrane. So what is the purpose of the grome? What happens is that eustachian tube solves the purpose of equalizing the pressure on the either side of the tympanic membrane. That is why we always feel the changes in the ear pressures when we are taking a flight or when we are taking on the higher altitude. So the purpose of the eustachian tube is to equalize the pressure. So what happens is that when there is an edema of the eustachian tube or the middle ear is filled with the fluid, eustachian tube is not able to equalize the pressure, and that kinds of sets the middle ear mucosa into the vicious cycle, because there's so much of negative pressure inside that it keeps on secreting more mucoid discharge. So just to break the cycle, what we do is we make a small incision in the tympanic membrane that releases the fluid for once, and then we put this ventilation tube. It is like how we whenever there is a negative pressure, we try to create a pressure pump so that the entire pressure cycle restores. So grome basically helps to restore the pressure cycle or the equalization of the pressure on the either side of the tympanic membrane. The gromes are not meant to stay there forever. They are usually made up of Teflon or silicone, and they get extruded on their own within 6 to 9 months. And by the time the mucosa heals, the eustachian tube restores its function and the entire system starts working on its own. So, grome, who should we really consider for putting in grome? It is indicated for children with otitis media with effusion. OME stands for otitis media with effusion, which means there is a fluid behind the drum. It is also known as serous otitis media. It is usually recommended for children with chronic otitis media with effusion, who have been had a hearing loss for at least 3 months, or children who are at risk regardless of developing hearing loss, and patients in which the chronic otitis media with effusion has caused a structural damage either to the tympanic membrane or to the middle ear structures. Now, coming to what are the surgical options in patients with ear discharge. So what I would like to emphasize is that in a patient with ear discharge, more than doing an ear surgery or treating the ear infection, it is important that we treat the cause. So it is more important that we consider them for removing the adenoids and tonsils, because the basic reason that why they are developing the ear infection is because they are having a chronic adenotonsillar hypertrophy. So in a patient with a ear discharge, our rate of doing adenotonsillectomy is much higher than actually doing gromes or dealing with the ear surgeries. Another surgery which we commonly do is doing a myringotomy with grome. This is done for patients with serous otitis media, as I already discussed. For patients who have a perforated drum, we have to do a reconstruction of the eardrum, which is known as a tympanoplasty. I would like to emphasize that the tympanoplasty surgeries are not done when the child is actively having an ear discharge. We need to make sure that we dry the drum, we dry the ear, we give a good course of antibiotics so that the middle ear mucosa is completely dry, and then we go ahead and repair the drum. In patients with unsafe chronic otitis media or cholesteatoma, we need to do a mastoidectomy surgeries. So I would like to end my talk by saying that as we all know that any stagnant water in a pond or anything becomes a source of, it becomes a medium for the algae and various infections to grow, and also it becomes the source of a foul smelling discharge. A very similar situation is what is seen in the middle ear cavity, because it is a closed cavity. If there is a stagnation of fluid in the middle ear, it will become a medium for various pathogens to grow, and eventually it will lead to damaging the middle ear structures and the eardrum. So, just as said by Nilima Bish, that any stagnant water, stagnation in life, or stagnation in thoughts can create problems. So, it is important that we keep moving. Thank you so much.
Right. Uh, Thank you so much, Shruti. It was an excellent talk, and you've hopefully made everyone understand the basic approach to ear discharges. So let's just get to some of the questions which are there. I'd once again like to thank all the delegates for joining in today. So the first question is from Dr. Sadaf Sheikh. What is the management of discharge coming out of the pre-auricular sinus or the fistula, and at what age should it be operated?
So, a preauricular sinus is a congenital deformity. If there is a sinus there, it is always at risk of getting infected. First, if there is a discharge from the sinus, the first and foremost thing is to dry the discharge. That is to give a course of IV antibiotic, make sure the discharge is dry. If the patient is developing recurrent discharging sinus, then it is mandatory that we remove the sinus tract fully, because otherwise it will keep discharging. There's no particular age at which you need to do. It depends upon the number of times that sinus is getting infected. So if it has just got infected once in a lifetime, you can just give a course of antibiotic and observe it. But if it is recurrently getting infected, you need to remove it, and there is no age at till which you should wait before removing it, because it is a passage. It is, if it is prone to get infected, you need to remove it.
All right. Thank you so much, Shruti. And then we have another question from Dr. Srilakshmi. After what age should myringotomy be done?
So, as I said that, so for all these situations, Dr. Avi, there are no age limits that, myringotomy should not be done in support. It depends upon the symptoms of the child. So, for example, that a myringotomy is indicated when the child has a serous otitis media or the fluid behind the ear. Okay. So, first thing first is that we treat the underlying reason the why the child is developing fluid behind the ear, which means that we need to take care of the upper respiratory tract infections. We need to make sure that the adenoids are not hypertrophied, and basically the nasopharyngeal opening of the eustachian tube is not getting blocked for some reason. If despite all these things the child is having a persistent middle ear fluid, the criteria for which I think I mentioned, that if the middle ear fluid is leading to hearing loss in a child, or if it is causing a structural damage in the child, or if it is a persistent ear discharge which is not getting relieved after all the courses of decongestants and the antihistaminics and all the antibiotics you have given, then you can always go ahead and do a myringotomy. And myringotomy is a very simple procedure. It is just creating an artificial nick in the tympanic membrane, letting the fluid flow, and then SOS you can think whether you want to put a grome or you don't want to put a grome. The nick in the tympanic membrane heals on its own. So there's no particular age. It all depends on the symptoms of the child and what we are treating basically.
Thank you so much, Shruti. So there's one more question from Dr. Suresh Rao. So one is, do you advise ear drops when there is ear discharge? If yes, then which one? And just a follow-up question to the previous one which you answered. Is it done under general anesthesia?
Yes, so the myringotomy procedure for adults can actually be done under local anesthesia, but since we are talking about children here, it is always done under general anesthesia because it's a microscopic procedure. It is, of course, it is little painful and it is a microscopic procedure, and we don't want a child to move when we are taking such a microscopic incision on the tympanic
Yes.
membrane. So it is we always do it under general anesthesia. So, what was the second
The
question,
second
Ravi?
question is by Dr. Suresh. Do you advise to put ear drops?
Yeah.
If yes, then which one? If a perforation is there?
Okay, so if perforation is there, definitely you need to put in ear drops. Okay, so thing is, if your perforation is dry, then there's no point putting ear drops. If there is a discharge, first thing first is get the discharge cleared and then put the ear drops. And I would also like to emphasize that more than the ear drops, what is going to help them is giving them a course of decongestants and the antihistaminics, because that will kind of restore the normal middle ear cleft ventilation, which will become a self-healing cycle. So yes, we do recommend ear drops for child with mucopurulent ear discharge. Normally what we recommend is betnisol, a steroid and an antibiotic mixture, which is a betnisol N or a neosporin H. Sometimes we also recommend Ciplox D ear drops because these are very commonly available eardrops.
Thank you so much, Shruti. So there are a few people, delegates who have raised their hands. So if at all you have any questions, I would like you all to please type down in the chat box so that I can let Shruti know. Till then, one more question which is there is regarding treatment for ear wax. What drops would you recommend and how long would you put it for?
So thing is, I would just tell you some small thing. It's a general information about the earwax. Thing is that earwax is a normal secretion which is produced by the external auditory canal to protect your drum. Okay, so it is not something that which needs to be cleaned very frequently, unless so in some patients, some patients may have a thicker wax which may tend to get blocked. So if you are one of those in whom the ear wax is very thick and it is clogging or blocking your ear periodically, then we recommend a Solivax or Waxo Clean karke there are ear drops. So normally what we say is that you these are oil based preparation which will dissolve the wax, but definitely it needs to be removed. It will just liquefy the wax. So we tell them to put 2 to 3 drops 4 to 5 times a day for 7 to 10 days, and then see an ENT to get a ear syringing done and remove the wax. Because just by putting the drops, the wax is not going to disappear. It is just going to dissolve the wax. Eventually, you need to see, and if you after 10 days of putting the Waxol or Solivax, if you stop putting, it will again solidify. So the recommendation is that you put Solivax or Waxoclean for 3 drops 4 to 5 times a day for 7 to 10 days, and go and see an ENT and get the wax removed. Once your wax is removed, if you think that you think the child has an extra tendency of producing a thicker wax and would need these procedures, what I recommend is that I tell the parents that you can put the Solivax drops or the Waxoline drops once a week, every Sunday, and because that will just not let the wax accumulate, And then just after, when a child take bath, even the water that goes into the ear canal is self cleansing. So you can just take the corner of the towel with which you are just drying the child, and just clean it like this. Because don't put the earbuds or anything, because the size of the finger is made by the god that it cannot go inside the drum, so it will not damage you. But because there are nails, you just wrap the finger like this on the on your towel, and just clean it from outside, so it will not let the wax get accumulated and block the ear.
Thank you, Shruti. If there are any more questions, please can you put it down in the chat box? There is another question. Dr. Sri Lakshmi asked, like, some people put oil in ears. Is it recommended?
So basically,
What do you?
I'll tell you something. It's a very commonly done thing, and a lot of babies come to us wherein those dyes or the caretakers, they put those oil. So I'll tell you the basic concept of putting the oil, especially hot oil they put. The aim was to do the same thing what Solivax is doing. But why we don't recommend putting the oil is because they are not purified. We don't know what is, whether it is. So these oils, the temperature at what they put is, it can cause damage. B, they are not free of infections and all those things. See, some children may have some reaction to the component of the oil, what oil they put. So we never recommend that you put any form of oil in the ear. Solivax technically is an oil based preparation for the same purpose. So it is much more purer form, and it does the purpose what it does not cause an allergic reactions.
Oh, that's great. Thank you so much, Shruti. So there's another question from Dr. Anil. So he has a case kind of scenario for you.
Yeah.
There's a child who's having recurrent right-sided otitis media
Yeah.
uh, due to recurrent acute episodes of URTI. The child is around 2 years old, and now it's been after 10 days of your local and systemic antibiotics, amoxicillin has been given, and the child improves. But how do you stop this recurrent cycle?
So see, first thing is that a child is having a recurrent ear discharge. As I mentioned earlier, you need to find out the cause of that ear discharge, which may mostly be lying in either the nasopharynx, nasal cavity, or the throat. Okay, so for throat, if it's a tonsillar hypertrophy or adenoid hypertrophy, it can be easily taken care of. So you need to start the child either on the nasal sprays, decongestants, and anti-allergics, and see how the child is doing. If the child is, then also get an X-ray nasopharynx lateral view. If it is causing if the adenoids are huge enough that they will not respond to the conservative treatment, you can actually think of getting that removed, and that will help the ear to get heal. And then we see that what is happening to because any which ways you can't just go and treat the ear unless you treat the underlying cause. Lot many times there is no adenoid hypertrophy, there's no tonsillar hypertrophy, they may have a simple deviated nasal septum. In children below 18 years of age, we never recommend that you actually go for a surgical intervention for the deviated nasal septum, but that thing can be easily taken care with lot of nasal sprays and nasal drops and decongestants. And the ear infection should get better once you treat the underlying cause.
All right. There is another question by Dr. Anil. What do you use to do ear toileting? Is it same as ear syringing, or is it something different?
So when I say oral toileting, I do not really mean that you go and syringe the ear, because already there is a discharge and infection in the ear. We have a special ear suctions where under microscopic examination or under a headlight examination, we clean it with a suction. If you do not have suction machines or a ear suction in your OPDs, what you can do is just take a swab stick, a soft cotton swab stick, and just clean the discharge whatever is visible to the naked eyes. Do not try to go very deep inside in the near the tympanic membrane, that your this thing may only cause infect drum perforation or anything. But clean as much discharge as you can. So when I say oral toileting, it means not the oral syringing, it means cleaning the ear, which is just making space for the eardrops to reach the site of infection.
Great. Then we have another question by Dr. Suresh. Which eardrop do you advise in otitis externa? And in the hospital, sometimes they pack the ear, and that he has seen that gives good results. Is there any preparation available at a local chemist which someone else can use?
Yeah. So, for otitis externa, as I already said, that the aim remains the same. The otitis externa is a infection of the external auditory canal. So we usually give Ciplox D eardrops or any antibiotic plus steroid eardrops, which is betnisol or some Neosporin H. The pack you are saying is what we use is a either a antibiotic soaked ear wick, which is maybe a fusidin or a mupirocin, or what works very beautifully is a GI pack. It's called glycerol ichthymol pack, GI pack. So glycerol ichthymol is a old age preparation wherein it has a component of, osmotically it reduces the edema. It has some local soothing effect. It has some antibiotic antifungal effect. So just putting that GI pack for 24 to 48 hours works beautifully in reducing the edema. What happens is that because there's so much of edema in the external auditory canal, even the eardrops are not able to reach inside. So what we do is that we just put a small pack there for 24 hours. It takes care of the edema because it has that hygroscopic properties of absorbing the edema fluid, and then it makes space for the eardrops to go in and medicines to act. So it is called a GI pack, which is available at some of the pharmacies. It's a kind of a locally made preparation.
Thanks, Shruti. Another question is regarding the safety and dosage of using steroid eardrops in children. Is it recommended? If so, what will be the dose? And how would you give it? And do you need to taper it or just suddenly stop it?
The thing is that all these we never use a pure steroid preparation. We use it with a preformed preparation that comes with the antibiotic. These are very fixed formulations, like it's a betnisol N or a Neosporin H, or a Ciplox D. These are preformed preparations, and we are not using these preparations forever. We are going to use it only to take care of the acute phase of the infection or the discharge. So usually the eardrops are given for the period of 1 to 2 weeks, which is okay. And these you don't alter the dose of the steroid in that. You're not giving, and it's a very topically acting steroid, so the absorption into the bloodstream is barely minimal there.
Thanks, Shruti. So let me just check. Yeah, so till I wait for a few more questions to come in, just wanted to ask, like, can you give all our delegates, is the color of the discharge play an important role when you're treating? Is there something which can help them guide, or is it that you just start antibiotics for every year discharge?
No. So that is the thing which there was a slide which I mentioned, that not all ear discharge will require antibiotics. Because I'll tell you something, most of the discharges are wax. The wax is a yellowish color discharge which is not going to respond to antibiotic. Second is, quite a lot of time, especially in this weather when there are monsoons, the cause of the ear infection and the ear discharge is a fungal infection. In that, you need to give antifungal drops. Sometimes there may be an underlying chronic middle ear infection superimposed with a fungal, wherein you need to give a combination of antibiotic and the antifungal drops, which are available in market. So these discharges are very whitish color discharge. A fungal discharge or a fungus will have a typical spores, black color spores, which will be seen on a otoscopic examination. So giving an antibiotic drop in a fungal infection is not going to help at all. What you can make out is that a color of the discharge is that if it is a mucopurulent discharge, which means a pus is coming out, then only the antibiotic eardrops are going to help. So if you are asking me about the color of the discharge, the pus is going to be pus. The pus may have a change color, like a greenish pus is more of a pseudomonas infection. A yellow pus is more of a staph infection, or a streptococcal infection. So it's like that. So the color of the discharge is not going to determine what antibiotic are you going to give, but it depends upon you listen to the features what child is presenting with. If it is a scanty discharge and a foul smelling discharge, then your aim should not be to give the antibiotic but to do a ear examination, because definitely there will be cholesteatoma flakes, and cholesteatoma is not an infection. There might be a superimposed infection, but it is a bone destroying disease which needs a surgical intervention. So these things need to be taken care of, that you need to understand the nature of the discharge. Any scanty foul smelling discharge, definitely refer to ENT because he will be a surgical candidate. Any mucopurulent discharge, think that you are either dealing with an acute infection or a chronic infection. If it's a chronic infection, then look for the cause in the nose or throat. If it's an acute infection, you can treat it with a short course of IV antibiotic and decongest and wait how the child responds. If it is associated with itching, you need to rule out causes like seborrhea, eczema, psoriasis, fungus, and if it is associated with a lot of pain and especially the tragal tenderness, then you know that you are dealing with an external auditory canal infection or a pathology like furuncle or otitis externa. So I
Uh,
hope I have not
uh,
confused everybody a lot,
No, no,
and
you've answered very well, and there are a lot of more questions coming in. So just
yeah.
before I just start reading those other questions, I'll just ask you. So, Shruti, now we know a lot of these conditions are being treated by our pediatrician colleagues and general physicians and everything. So, as a ENT specialist, uh, what would be your guidance to them? Is what is the point where that child should see you once at least so that the treatment goes well? Or is there something like that, is that now this is the time where the child's ear should be checked by a specialist, or is anything like that? So if you can guide our delegates till then, I'll get to the other questions.
So I'll give you certain specific situations. One A, as I've been repeatedly emphasizing, any scanty, foul smelling, prolonged intermittent discharge needs an ENT reference to rule out cholesteatoma. Okay. So scanty, foul smelling. So it is very important that you just take a discharge on your swab stick and smell it. It has a very, very typical smell. That's the only way to find what is the foul smelling discharge and not a foul smelling discharge. And patient, if you ask the patient, now they will also give you a typical history that yes, kaan ke pani mein se baas aata hai. It's a very typical rotten fish kind of a smell. That so any that foul smelling discharge definitely needs an ENT reference. You must not wait and just keep on conserving the child. Okay. Second thing is, if there is any history of head injury and then the child is presenting with a watery discharge, then you are dealing with a CSF leak. That becomes a different ball game altogether. So any patient with head injury followed by a watery discharge, you though we are going to conserve with that only, but definitely then it becomes a different ball game altogether. Third thing I would say, if the child is having ear discharge with itching, most commonly, I will not go into the rare causes like psoriasis or eczema or all these things, but most commonly, very commonly, it is otomycosis or fungal infection, which will only improve once you remove that fungal pathology from the ear. So even giving the fungal drops is not so. Whenever there is a fungus in the body, you need to first remove it and then give antifungals. Okay, so I think if the child is presenting with ear discharge and lot of itching or irritation, then you need to refer it to ENT, because then it needs a proper thorough cleaning of the ear under the otoscopy guidance or microscopy guidance or headlight examination. Fourth thing is that if the patient is presenting with recurrent ear discharge and you're not able to understand the pathology, I would say that at your level you can think of just do a ask for other symptoms like, does your child get recurrent upper respiratory tract infection? Does your child get recurrent sore throats or difficulty in swallowing associated with fever? Does your child has snoring? Does your child has a mouth breathing? Does he sleep with his mouth open? These few questions will give you enough information that you are dealing with a adenotonsillar hypertrophy, which is actually the cause of your recurrent ear problems. If you think that the answer to these question is yes, then you should refer the patient to a ENT specialist, because then he will need to be taken care in a different way altogether, maybe a surgical intervention or what. And another thing I would say, that if also ask, there is there a history of a hearing loss? If you think there's a history of hearing loss, either do a tuning fork test in the OPD or send the child for an audiological evaluation. If there is a documented hearing loss, then I think there is a role of a ENT to play in. So otherwise, basic rest of the things you can just manage at your level with whatever we have discussed in the presentation right now.
All right.
But these things definitely need a specialist reference.
All right. Shruti, there are a couple of more questions. We'll go a little quickly. So another one from Dr. Anil. So he has asked, so tonsillar resection for adenoids, it should be done at any age below 5 years, or should you wait for it to heal naturally? He is worried about the ossicles in the middle ear, and how do you know whether the ossicles are getting damaged because of the adenoids?
So I'll tell you something. There was there was a long-term discussion. Every time it was said that tonsils and adenoids should not be removed in a children below 5 years of age. I will not agree to that. Yes, ideally you should wait till the child is 5 year old only, but you have to weigh how much problem this is causing, because adenoids and tonsils are not adding so much to your life if they are giving you episodes of upper respiratory tract infection and fever every 2 to 3 months. So there is a criteria which is known as a sign criteria, wherein when you actually ask that how many episodes per year your child is suffering. If you are fulfilling that criteria, for example, if you are having more than 7 episodes of upper respiratory tract infection in 1 year, or more than 5 episodes every 2 year, so forth and so forth, if you're fulfilling that criteria, then you can remove. We have removed the adenoids in a child who was 1.5 year old also, because it was, rather than giving the whatever the immunity or the protection, it was causing much more problem. Because once the adenoid is going to cause the middle ear fluid, and if it gets infected, it is going to cause ossicular destruction, as sir has just mentioned. So coming to the second part of the question, how will you know? See, the only way to see whether the ossicular destruction has happened is doing a CT scan, but that is not recommended. There are indirect ways. Whenever there is an ossicular destruction, there will be a lot of events which will be happening before ossicular destruction, right? It is just not that inside it is causing the destruction and the child, it is an indolent disease. No, there will be a earache, there will be ear discharge, there will be a perforated drum, and then there will be ossicular destruction. B, your tuning fork test will definitely tell you that a child is developing a hearing loss. Any ossicular destruction will lead to the hearing loss of the level of 50 to 55 decibels. So that is a lot of hearing loss. It's a moderate to moderately severe hearing loss. So definitely the child or the parents will tell that he is not able to hear from this. So there is a lot of pre-sequelae that happens before the ossicular destruction happen, where you will be able to pick up what is happening to the child. And third, definitely doing an audiogram will give you a very good information what is the hearing status of the child.
Excellent. Thank you, Shruti. So there are a couple of questions which are similar. So I'm just going to club them. So they are
Yeah.
regarding foreign objects in the external auditory canal, like a insect or a groundnut. So if something like that happens to a child, is there any immediate first aid treatment which should be or can be given till the hospital reaches, till the child is brought to the hospital?
Any foreign body in any orifice of your thing needs to be removed. Okay, so any foreign body, especially in a place like an external auditory canal, especially when it's something like an insect or a groundnut, it needs to be removed. Having said that, there are some foreign bodies which are non-emergency thing, like a paper ball, or something which will. So a groundnut is an organic foreign body. It is going to elicit a reaction in the mucosa, and eventually there will be edema around it, and it will become more and more difficult to remove if you put any eardrops, if you put water, if you put oil, or even if you just wait. So it needs to be removed there and then. You have a window period of few hours. I mean, it is not that it is going to cause infection or perforation immediately. You have a window of 3, 4, 5, 6 hours. You can wait, but there's no alternative. You just need to remove it. That's the only way
All
to
right.
look at it.
And there's another question by Dr. Meena. When are boric acid eardrops used? What is the preparation available in the pharmacy?
Honestly, I am not aware about this because we don't use it anymore. I have heard that it was being used at one point of time. I am not aware. I mean, I'm not using it for any known indication
Indication.
at present.
And
Uh,
yeah, please continue.
no, that is all that
Okay.
I'm not aware.
So Dr. Suresh has a question. So in a crying infant, can you give some tips and tricks how to examine a child with the otoscope, especially when they are crying, howling, and are not allowing examination?
This is what I have learned after I've joined this hospital. I'm a ENT practitioner and I'm not a pediatrician, but I've learned to deal with the orifices in the children, like, especially ear, nose, and throat. The only way is tell the parents to hold the child tightly, because you really need to tell them. And there is a specific way I've learned that, you just tell them to put their legs between their legs and hold it, put the arms cross and put it, and just hold the ear and put it against the chest and make the child not move at all. Because if you try to go and examine the ear, and if a child moves, your otoscope is going to cause injury in the external canal.
Yeah.
So the only way is to hold the child properly and do an examination.
Uh, that's great. Thank you, Shruti. The other thing is, again, another question from Dr. Anil. Is there any second choice of antibiotic for acute bacterial upper respiratory tract infection with ear discharge besides the penicillin and cephalosporin, which you already mentioned?
There are a lot of antibiotics which you can give. You can give any group of cephalosporins. If the child is penicillin resistant, we can also give clindamycins, and there are actually a lot of group. I mean, because the main causative organism is staph, strep, morozella, and H influenza, and we all know that these are
Sensitive.
sensitive to quite a lot of
Yes.
antibiotics. Yeah.
Thanks, Shruti. So one more question is by Dr. Sri Lakshmi. She said, what is your advice to people who have a habit of frequently using earbuds and sometimes the indigenous type of earbuds, where sometimes the cotton part just stays inside the ear and the stick comes out?
See, for
So
any patient, I always say do not use earbuds. I always write in capital on every prescription that do not use earbuds, because the earbuds are not only going to cause the local trauma, but earbuds are also known to cause long-term hearing deficits in patients, because they cause sudden pressure changes in the drum. So I just tell them do not use earbuds. They are not recommended. And I have learned that earbuds were actually not meant to clean the canals from inside. If you actually see the formation of the earbud, they were supposed to clear this part of the ear, which is, the tracheal part and the pinna, the crevices of the
yeah,
pinna. So earbuds were meant to clean that. So I just tell them, I tell the parents, no, do not use earbuds yourself. Do not use earbuds for your child. Do not, I mean, earbuds are complete no-no. That's the only
because
thing.
I've
I just
seen a lot of those caretaker maids. They just put the earbud right inside
yeah,
the ear
yeah.
to remove off
There,
everything.
I have seen people sitting on the, I was in KM and I have seen people sitting outside Elphinstone station with the mirror and cleaning. So there are a lot of people, but I'm telling you, it's not only about damaging the external canal, because that can still be taken care of, it will heal. But it is much more than that. The earbuds can damage your drum, and it can cause the pressure changes, and which are transmitted to the inner ear and cause fluid, all the havoc in the fluid, and then cause a sensory neural or a cochlear hearing loss. These are a lot of things which happen with the earbud. So it should not be done.
Oh, that's great. Thank you so much, Shruti. And we, as usual, are perfectly on time. And we've
Yeah.
had a wonderful discussion, and we've had almost more than 100 people, 98 on the Zoom, and a few on YouTube. So more than 100 people who've been there with us till now for this session. So thank you so much, Shruti, for your wonderful talk. I just like to check if my co-moderator, Dr. Hiren, is he around?
Hiren, you are on mute.
Hiren, you're muted.
Oh, sorry. Yeah, I'm
Yes.
available now. I'm free now.
So
So
I'll just introduce Hiren so that then he can introduce the next speaker.
hmm.
So we have Dr. Hiren Panwala, who's our resident in-house radiologist, who is always available for all of us 24/7 for every image we don't understand. So I'll hand it over to Hiren now to take over from here.
Thank you, Avid, for that nice introduction. So without further ado, I would like to invite Dr. Rakesh Shah. So Dr. Rakesh Shah is a consultant pediatric ophthalmologist, and he's a very well-renowned name in the field of vitreoretina, cataract, and laser refractive surgery. He has done his MBBS from KEM Hospital, Mumbai. He also has done MS from JJ Group of Hospital. He has done fellowship also in vitreoretinal um, surgery from Retina Foundation, Ahmedabad. And he has got very vast experience, almost 18 years. And I'm glad that I've been working with him, and he's showing me some wonderful cases that he's treating the patients. And with that, I would like to invite Dr. Rakesh Shah to share us with his topic. Dr. Rakesh Shah, please, the stage is of yours.
Yeah, am I audible, Dr. Hiren?
Yes, sir. Now you're comfortable.
Yeah. Thanks, Dr. Hiren and Dr. Avi, and thanks, Dr. Shruti, for this wonderful talk before me to start a session for this. I would just go and start my session. Yeah. So I have a vast topic today to cover, the eye disease in the newborn, which is something a huge topic to cover. But then I'll just see I cover up the overall what we are seeing regularly in a day-to-day OPD. We have a lot of this condition coming from as a congenital disease, either from genetic or intrauterine insult or acquired. Now, why it is important to diagnose all these conditions very early in the life, just to have prompt treatment to avoid lifelong visual impairment. If you don't detect and manage it in early childhood, it's going to really not having not only visual consequences, but also developmental delay for the child and for entire family. So that's the reason first neonatal checkup is very critical to find out any structural abnormalities like cataract, glaucoma, corneal opacity, or any lid problems, or deaded tumor like retinoblastoma. So what are we looking for a congenital problem? Primary because of some genetic conditions or because of some intrauterine effects of drug, alcohol, or some blood sugar level in the maternal area. We do have a lot of this genetic issue like disorders of the globe, disorders of the overall disorders in the retina. It may be because of infection in terms of torch infection, which is coming up with a lot of this chorioretinitis, congenital cataract, or some other infection like rubella, varicella zoster, or Epstein-Barr virus. The alcohol, which is quite common, we do see a lot of this fetal alcohol syndrome coming with optic nerve hypoplasia or some cocaine, or sometimes the mother is already on antidepressant or some anticonvulsion or a maternal diabetes. The acquired, something which is very really common, what we see is ophthalmic neonatrium, that is a congenital, the infection in the eye or a retinopathy of prematurity. We do see secondary because of all these issues, the strabismus or the squinting and the lazy eye or amblyopia. So why it is important to find out? Normally the child will present with some discharge or a swelling or a yellow reflex from the eye or not focusing on the eye. In the newborn, we see a lot of this cellulitis coming up. So a lot of this cellulitis comes with a mild redness or a swelling. If there is no surrounding involvement, if there is a lid is minimal edema primary because of in the anterior part, there is a preseptal cellulitis. We do see a lot of this child with a deeper, that is orbital cellulitis. So it is very important to identify the preseptal from the orbital cellulitis because of this later part require IV antibiotic. Most of these infections either related to some trauma or because of some sinusitis or some internal infection which need to identify as a source. The another common thing which most of the child present is a nasolacrimal duct obstruction. The parents will always say there is some watering coming from the child. That is in the infant. What we see, a lot of this child coming up with this watering either in the both the eyes or primary in the one eye. Now these disorders are primary because of nasolacrimal duct obstruction, and sometimes it is just a primary minimal watering it is coming. Sometimes it get infected, and then we do see a lot of this child coming with discharge. There are certain congenital anomalies like lacrimal puncta, which is not formed, or there is a fistula which is from lacrimal sac to the directly on the skin, or I do see something like a decrocystocele where it is totally blocked, and we see the infection and the swelling on the lacrimal sac area. Now it is important to identify not all these child require any urgent treatment. We ask parent to clean the eye regularly, apply sac massage on the corner of the eye just to clean all this discharge and regularly cleaning. We do have to give certain antibiotic eye drops to such child. If within over a period of time, next 3 to 6 months, if child is still having a persistent discharge, we do think of doing a probing to find out the anatomical patency of the nasolacrimal duct. and then in require, then only we advise for the further surgery. But 90% of the child improves with a plain antibiotic drop, maintaining the hygiene and with safe massage. We do see a lot of this child coming with infection. Now, there is a broad range of conjunctivitis which comes in the neonates or in the childhood, and which label as a ophthalmia neonatum or a conjunctivitis occurring in the first few months of the life. This could be a various etiology, from chemical to bacterial to herpes simplex or even Neisseria. Now, these are severe from now very rarely seen, but yes, in the few poor hygiene conditions and everything, we do see this severe infection coming in the child. Maybe because of chlamydia trachomatis or a herpes. Usually herpes comes in the second week. First week usually more of bacterial or a chlamydia type. Now a lot of these hematomas growth coming up, and which we commonly see some red color swelling, which child the parents will commonly notice and come with the hemangioma. These are the common hemangioma, which may be a periocular primary from the proliferative capillary endothelial cells. The another common what we see is a port wine stain, which is primarily because of development anomalies from the capillaries, which may be venous, arterial, or lymphatic. The most important, which we are really, which is quite common, and child present with a yellow or a white reflex, the usually 3 to 6 months, when the parent notice there is a child is not able to focus, and then we are seeing the white or yellow reflex, and then we really need to identify, is it a cataract or is it some internal problem because of retina, or there is some tumor. Now, cataracts are the congenital cataracts are very common because of systemic syndromes, because of infection, because of trauma. These are the various type of cataract what we see in a child. Now, this may be anterior polar to posterior or a lamellar, which lamellar being a very quite common. Now, again, in various type of congenital cataract, which we really assess, we need to see if it's affecting the visual axis. If it is affecting the visual axis and it is not allowing vision to develop, this cataract need to be removed early. There are certain small cataract which is not affecting the visual axis. We can just put a dilating drops and keep dilated for a few times and then operate at a later stage. But if it is something which is affecting the vision, it has to get operated as early as possible. These are the few other congenital disorder which we sometimes we see in our OPD practice. It can be either total absence of lens or the lens has been displaced from this normal position. This may be a part of the syndrome, which again we need to find out from the system and see if there are other systemic disorders along with the eye problem. Sometimes because of there is a persistent PHPV, that is a persistent hyperplastic primary vitreous, which is there, which may lead to various either a cataract or a mid-ended stop on the behind or a certain Burmester papilla on the optic disc. Now again, these are the various part of the remnant of the embryology, and then we need to find out and treat it accordingly. Something which is very close to my heart, and then I really want all the family practitioners to have a really worry about, is a retinopathy of prematurity. Now with the excellent NICU setup, and then we are able to save very small preterm babies. We are seeing a very high incidence of ROP coming not only in the government hospital, but sometime in a private setup also, with this not controlled NICU setup. There are a lot of issues. A small video about the ROP. So ROP is something which we need to really identify on time. All premature babies, or even in India, the criteria is below 34 weeks, and then baby with a below 2 kg weight has to be examined within 30 days of life. There is another entry called aggressive posterior ROP, which is usually we see in extreme preterms. So all these baby which are below 1.2 kg has to be examined for the retina checkup by second to third week of life. And all other babies which high risk factors in terms of sepsis, transfusion, respiratory distress, admitted for various reasons in NICU, need to examine before 30 days of life. Based on our ROP retina checkup, we identify, and in such cases, these are the different stages what we see in terms if there is a child is developing ROP. That is initially from stage 1, there is a mild demarcation line to a ridge which is getting a two-dimensional structure, to a ridge with extra retinal proliferation where I can see the ridge is overgrowing, there are blood vessels which is crossing. Stage 4, we again see a detachment, and stage 5 are totally non-operable. So ROP is the only way where we can, prevention is the only cure if we identify on time. So how do we examine all these baby? Again, the question to the previous question, speaker, again, how do we examine this small baby? We have a good covering of the baby. We put a small pediatric speculum, put an anesthesia drop, and then we examine child. We dilate the pupil. All these baby require a thorough checkup, including if there is a ROP treatment is required, we do the lasers. Again, this is done in NICU when baby is already in NICU. If this is already discharged, it has to be done in the OPD setup. In some baby where there is a AP-ROP or very aggressive posterior ROP, we need to give an intravital injections inside the eye to stop the VEGF production. There are certain baby, in spite of heavy laser, which we still progressing. In such cases, we do have to, especially if some child, which is, we recently had one baby which came to SRCC on the day 45 of life and admitted later. So such baby which has not been primary treated in the early stage of the life may go into very advanced ROP and then may require a surgery also. This is a simple camera what we have. This is a Forus, it is an Indian made red cam camera which has a good where we can do the diagnostic and the entire retina evaluation. So you can actually see we put it in the baby's cornea and examine the baby's posterior segment. This retina can be clearly seen. These are the all retinal blood vessels where we can see a stage 2 ROP with a demarcation line with a ridge. This is a normal retina. This is in the aggressive posterior ROP with a lot of these hemorrhages, and then aggressive looking, the angry looking, the blood vessels. These are which with plus disease. These are the happy mother, because all these babies which are treated on time usually recover well, and then they have a good visual prognosis. The child almost 4 years of life, and then we do get such happy messages coming from the parents where they have seen starting from 15 days of life to now almost 2 years. Now, another entity which we started recently is a retinal vasculitis, which is now very little uncommon in the neonates. Now, we have recently seen query post multi-system inflammatory disorder query with the post-COVID, but we see a blood vessel which has been totally inflamed. And all this has to be detected before, on time, before the 30 days of life, because if this blood vessel is blocked, it is going to permanently damage the fovea, and then child will have a poor visual prognosis. We do see a lot of these scattered hemorrhages coming on the retina because of thrombocytopenia or certain infection. Again, all these need to be identified on time. Now, another thing which we really worry and then we need to detect on time is a retinoblastoma. That's the most common tumor in the neonates and the infants. So that's the most common tumor, the primary malignant tumor. There is no sexual reproduction. We have coming and seeing baby before 3 years of life. These are the various ways this retinoblastoma can present in terms of leukocoria, the white reflex, in terms of squint. You may see a secondary glaucoma or the rise in eye pressure. If it is already invaded the anterior segment, we see invasion in the anterior segment or the orbital inflammations, or if it is totally involved the orbit. Now it could be a flat lesion, which is a more of endophytic variety, or is a placoid lesion, what we see on the retina. On a more advanced stage, if it is a progressing, if it is already exophytic, we may see a detachment. Now, all these retinoblastoma need to be detected on time. We also go and find out CT scan to just find any optic nerve or a brain extension. Based on the size of the tumor which require a treatment, in terms of small tumor can be managed with a laser or a cryo or a transpupillary therapy. If it is a medium tumor, require a chemo and brachy. If it is a very extensive tumor which has already affected the eye, require a enucleation of the eye. Again, we need to find out extraocular extension and then treat it accordingly. So all these poor prognosis factor in the retinoblastoma are something like optic nerve involvement, choroidal invasion. If it is a large tumor, it is an anterior location, or if it is an older child. Now, what are the other differential diagnoses in case what we see? We do see a lot of this yellow reflex or white reflex coming from congenital cataract. It is a PHPV. If it is a persistent hyperplastic vitreous, that also can lead to this. It is some membrane on the pupillary area. If it is a Coats disease, again one sort of vascular disorder for the retina. If you have toxocara infection, or it can be an advanced ROP with a detachment, also can lead to yellow reflex. So there are a lot of other congenital problems which are because of defective formation from the birth, and there are a lot. I'll just go give an overview about this. There's something like there is a globe is not formed, it is a partially formed like an enophthalmos or a microphthalmos or a cystic eye. And there is a problem with the eyelid disorder where eyelid has been totally fused or it has been hypoplastic like cryptophthalmos or aviliphron, or it is a partially there is a gap, that is a coloboma what we see, or that is a fusion ankyloblephron. So all these are quite obvious and we can identify early. Sometimes we see child with a ptosis, that is a drooping of the eyelid. Again, need to identify it is a congenital or it is a because of some acquired causes. Now there could be a lot of this craniosynostosis or a fusion of the bone and then can lead to altered facial configuration. So there are a lot of this syndrome which is like Rosen or a Eppert syndrome, or we see a Pfeiffer syndrome, which is a craniofacial malformation. There are certain non-synostotic craniofacial condition also like a golden hair syndrome where we see a lot of this dermolipoma or dermoids coming on the eyelid area. It could be because of uh, poor formation of the second and the third brachial arc, which causes a problem with the mandible, also in the eye also. So these are the various deformity which we occasionally see in our OPD setup. Again, the neoplasm, other than retinoblastoma, we also look for the rhabdomyosarcoma because that can come at any age, not only in the big child, but in the younger child also, or a certain like lymphangioma. Another which common thing which what is seen in the OPD is a dermoid cyst or epidermoid cyst, which is like outpouching coming up from this area, from the lid, from the angle. It may have with some dermal appendages like a hair follicle or a sweat gland or sebaceous gland. If it is affecting the vision, then all these things require a surgery. If it is not affecting vision, we do treat such patient conservatively. So these are different microphthalmia which we identify. Sometimes there is a defect in the bone where we see the brainy tissue coming out. There's a meningocele, or a teratoma where there is a multiple tissue derived from all three germinal layers. The another thing what we are commonly saying is a micro or the megalocornea. We do see child coming with a total opacification or the hazy cornea, which is primary because of certain dystrophy in the cornea. The Peters anomaly, which is very common, where there is a adhesion between the kerato, iridae or lenticular, that is the iris, lens, diaphragm, and then such child may get a only corneal opacity, or there is a cataract, or there is a synecia in the anterior segment. Again, timely identification for all these disorders and treating properly, that is something which is a treatment for all these child. We do see a lot of this congenital glaucoma. So when there is a totally opacified cornea, which I have to identify it is a primary because of corneal dystrophy or because of some congenital glaucoma. There are certain changes in the pupillary area, which may be because of small pupil is a meiosis or it's a mydriasis, or a altered shape in terms of polychorea or a tube pupil, or a small pupil which is distorted and displays externally. So these are the different stages which we see on the congenital glaucoma. We need to identify, treat it on time, either with medically and the surgically. The optic nerve, again, as I told you, we do see a lot of this optic nerve hypoplasia either because of congenital anomalies or because of fetal alcohol syndrome. And there are different like morning glory anomalies. So all these problems can be timely identified with a proper eye checkup, with a retina checkup, and then we can be treated on time. So we do get a lot of references now from our other pediatric consultant about the multiple systemic disorders and their ocular association. There's a huge list of this systemic association, but there's something what we see is a congenital toxoplasma where we see there are development delay, there are various degrees of retinochoroiditis and the scar on the retina. Because of rubella, we see a lot of this cataract coming up, or because of cytomegalovirus, we see chorioretinitis. We do get a lot of these problems in the metabolic disorder because of primary in terms of amino acid metabolism, that is a homocystinuria, cystinosis or albinism. So primary all these cases we do a lot of see in terms of changes in the iris, or we see a congenital cataracts coming up, or there are changes because of in cystinosis we see a lot of these crystals coming on the cornea, or there are pigmentary retinopathy. Again, a lot of this amino acid metabolism can cause displacement of the lens, that is ectopia lentis. There will be increase in the myopia. There are associated optic atrophy and the retinal detachment also. So primary, we look for any of this pigmentary retinopathy, night blindness or myopia in all these cases, and then work along with the pediatrician to have a appropriate treatment for all these babies. There is something galactosomia, and what we see very commonly oil droplet type cataract coming up because of a defect in the metabolism of the galactose. There is a huge list of metabolic disorder what we have, and then based on the other systemic symptoms, we treat it accordingly. Something which is very common, what we see in hallmark of Wilson disease is a KF ring, that is a deposition of the copper in the descemet area, and we see this brownish ring. So again, we get a quite commonly and associated with the cataract, which is a typical cataract which we have. Oculocerebral renal syndrome, again, we have associated cataract and then microphthalmus in such baby. So there are a few pictures which are taken from our American Academy of Ophthalmology and my Kansky book. I give a special thanks to my co-consultant, Dr. Sahana, for helping me in these presentations. And thank you very much. If you have any question, I'm open to the question. Thank you. Dr. Hiren, yeah.
Thank you very much, sir, for this lecture. I was not knowing that pediatric ophthalmology covers this many conditions. It was eye-opening for me also.
These are only for
And I
neonates.
have not.
These are primary just for neonates and the infants only. There are
Oh,
huge
this is
more.
only for neonates.
I have not
Oh my
covered
God.
squint. I have not given overview about the squint and the amblyopia and other refractive errors and a lot of other retinal condition what we see in the bigger children.
Correct.
So primary few things which was of really interested is the ROP, which we regularly see, the congenital cataract and the development malformation, which we really look for in all these young babies.
Okay. And you want to say that which days, sir, you are available to SRCC for these kind of OPDs and all if they want to come here?
No, we have.
So that
I am available on Thursday, but we have other pediatric ophthal available every day. So and
okay.
now we have full-time optometrists available in SRCC. So a child can be get screened anytime, Monday to Saturday, and then we have other on-call doctors on Sunday also. So
Oh,
there is
great.
absolutely SRCC is fully equipped with all our ophthalmic facility for all children.
Okay. Thank you. Anybody else have any questions? you can directly ask. We have some time. We can discuss for at least for 10-15 minutes. So even a silly questions I will be able to answer.
Request all the family practitioner primary to identify and at least inform their patients about retinopathy of prematurity, because that is something all preterm baby require a eye checkup. Many of the times these babies are already discharged, they are not being treated in their NICU for a primary eye. So baby is saved, but then eye is not saved. So all this, if they are already in touch with their parents, need to inform that they get first eye examination before 30 days of life.
Okay. I can see from chat, Asfi Mehta asking about great talk. Can we have PDF so that we can learn or something? Okay.
Yeah, I'll get everyone's email ID and then probably we'll share our PDF talk to all the practitioners, since we have emails from all these doctors who have attended today.
Yeah. There is one question from Dr. Anil Hardas Malani.
Yeah.
Any specific disorders seen in newborn in the COVID era? Have there been any concern in newborns if mothers have suffered from COVID-19 in the third trimester?
Yeah. So that's basically two photographs. Now these are still unpublished report, but we are working on it. And that two pictures what I had shown is a retinal vasculitis. Now there are another at NICU. We have seen almost that 10 baby which had a multi-system inflammatory disorder post-COVID, and then we had seen this vasculitis coming up. Another picture again that was with multiple retinal hemorrhages, but that baby and the mother both had a COVID positive. So a lot of these hemorrhages, retinal hemorrhages, and then vasculitis patients are just turning up post-COVID, but then there are still very scanty cases. We still don't have a published report on that. We still don't know it is primary because of COVID or because of certain other treatments which are already going on in such COVID inflammation. But then we need to keep a close watch on all these baby which have already has a history of COVID in the past from mother side, or primary the child had a COVID antibody positive.
Okay, great. So like in those patients which you saw, like the vasculitis was severe enough or it was mild or?
No, it was mild enough because since we detected early, we detected on the third week only. And then baby was already had some coronary dilatation, which probably Dr. Priya will elaborate because that was a case which we were jointly handling. And since once the baby was started on the steroid, immediately the vasculitis resolved within 2 weeks. And there was no long-term problems with the vision. Baby is doing well. So we do treat such baby conservative. We do require still very aggressively, but yes, need to be every baby need to examine by 30 days of life practically, not ROP or a premature baby, but then every baby is now with a now national guidelines for congenital malformation or ROP or a cataract. So first checkup has to be done by 30 to 45 days of life.
Okay. So regarding that only, Dr. Anil is asking again that if these ROP related changes can develop later in life, and it can possible that they can develop after 3 months, or it is mostly in
No,
within 3 months.
so great question, Dr. Anil. But then ROP is something which has to be detected on time. So by the time you don't examine for first 3 months and ROP has already started, it will lead to the total detachment. And the surgical results are not very great if the child has already reached to stage 4 or stage 5. So we do operate, but then the results will be very, in the best of the hand in the world also, the surgical results are not going to be great. So
Dr. Rakesh, actually the question was something like, if you had screened the patient already and there was no ROP, and then will it come later after 3 months?
No, so that is not possible basically, unless because now there are a lot of centers which just treat the baby on anti-VEGF injections and then they don't follow up. That is the only case where we see a child has regressed with the ROP and then come later stage after 3 to 6 months. But then someone has already been screened and been treated, there is very unlikely it's going to have a ROP changes after 3 months.
Okay.
Now we have a lot of these anti-VEGF injections which we give in such cases where aggressive ROPs are there. And the results are really phenomenal.
Okay. So you are talking about the laser treatment in the ward itself, like, so how safe and sterile, like, is it a daycare procedure or like how it goes like?
Yeah, it's a daycare procedure. So normally Laser directly will be done in the OPDs or in the NICU. Basically, if child is very uncooperative, then only we give little minimal sedation, but then it can be done at OPD or our emergency in the OPD place only. Most of the time these babies are in NICU, so then it is done safely. But then there are few babies who are already doing well, but then we keep on close watch and then we see on the follow-up. So then such type we do it in our OPD setup.
Okay. Uh, then again, Dr. Anil is asking, if a child has a squint at birth, is it necessary to operate earlier or wait for 1 year or so?
Yeah. So again, as I told you, I have not covered the squint because it's a big topic in itself. But then all squint do not require surgery so early. First of all, you need to find out is a true squint or a pseudo squint. Sometime because of just a pseudo squint, which next 1 to 2 years of life, which covers up because of the change in the facial anatomy, and then you don't require any surgery if the extraocular movements and the fundus, that is the retina, is fine. Now for the squint, again we need to identify it is primary because of refractive error or because of some non-refractive vision. So if it is a refractive error, then we need to give glasses to such child and then follow. If child is developing lazy eye, that is a poor vision, then we require a lot of vision therapy in such child. And then afterwards only, if in spite of treatment with glasses and then therapy it is not improving, then only we think of doing a squint surgery. Again, it's a gross squint, which is a like very high angle squint, then only we do it early surgery, but not immediately.
Okay. Just a silly question from my side, sir. Because of this COVID era, so many children, they are not able to go to school and they are spending most of the time in their home. So that leads to much more time seeing on television or like laptop or like seeing YouTube or whatever, like a cartoon series or something. So like what will be the optimal duration that we should allow, or like is there any preventive measure so that we can prevent the damage to eyes, like anything like?
So now practically this is a problem from a small kid like a 1 year to adult. Everyone is on the mobile because of lockdown. So everyone was used to mobile or a screen either on the TV. And then simple precaution which we need to really say is because why we are doing this is we are seeing a lot of sudden increase in the myopia, that is increase in the number coming up all this wavy. Most of the time it is a small screen they are seeing on the mobile rather than on a tab or a laptop, which is again causing a lot of strain to their eyes. Now at home they are not regularly cleaning their eyes, so simple cleaning with a simple normal drinking water or splashing of the water is what is more than sufficient. Again, angle what which usually we advise is always keep your height up and screen little down 20 degree below eye level. Take a break of after 2 hours, at least take a break for 2 minutes, wash your eyes, blink your eyes. And in spite of that, some child is still blinking or having a lot of rubbing, we do advise some lubricating eye drops. Now there are a lot of emphasis is put now with media is about giving a blue blocking or a anti-glare glasses. Yes, that is a added support, but not from the basic support like regular cleaning their eyes, getting a proper angle, having a good hydration, that is a drinking water, and then having a good healthy food in terms of fruits or a dry foods and the nuts. So I would rate glasses as one of the fifth option, but not in the first four. So all this child to adult, everyone has to see that they regularly clean their eyes, blink. So every half an hour need to blink for at least consciously for 2 seconds. Every 2 hourly wash your eyes and then have a good hydration in your body, which is going to help you in a long run for child to adult, everyone. And if you definitely have glasses, now a lot of these children who already had a glasses, they had stopped wearing glasses because for them reading or a computer is very near. So they had stopped wearing glasses, and all these child also had a jump in their myopia. So that also need to be really looked after. If you have glasses, get it properly checked and see that you wear a proper refractive error glasses. So which is now practically every ophthal or every optician is available, but get it checked every 6 months.
Okay, thank you for that answer. Uh, Anybody else having any query, you can ask.
Yeah, so there is another question from Sri Lakshmi, that is like, is it safe to use lubricating drop for a long period? Now again, based on the amount of dryness, we advise a lubricating eye drop. Now someone who has that profession of using for adult, we do advise a lubricating eye drop for a long time. But a lot of this lubricating eye drop has a preservative, and then preservatives are also harmful for our ocular surface. So as I told you, simple cleaning is more than sufficient. If it is still causing a lot of blinking or rubbing, then only we advise lubricating eye drop, but with a proper care. In a child, unless it is required, we don't advise. But in adult who has long hours of computer, mobile or driving, yes, we do have to give certain drops for twice or maybe thrice in a day on based on their work schedule.
Correct. Okay, I think if everybody doesn't have any question, then we can move to our next speaker. Okay, one more question has come. We can take that. What is the commonest cause of congenital cataract and congenital glaucoma? How early would you replace the cataract lens, and how long would you treat congenital glaucoma medically?
So a lot of this infection, the toxo and the rubella cause a lot of this congenital cataract along with a lot of these metabolic disorders. And any cataract which is affecting the visual axis has to remove as early as possible, because that lead to long-term damage to visual development and the amblyopia. So we suggest, based on the pediatric ophthalmologist or our examination, we examine, and if it is feel it is affecting the visual axis, yes, we do operate cataract early. To put IOL during same sitting, or we need to put it after 2 years, that is a doctor discretion based on the other pathology in the eye, but yes, cataract has to be removed. Now glaucoma, based on the what glaucoma we are treating, we do treat initially medically, but then many of these glaucoma require surgery. Again, that has to be done as early as possible. So thanks Dr. Anil to get this question, but all this, both this can cause permanent damage to the vision and has to be treated early on time.
You showed us, sir, some various kind of pupil
Anomalies,
changes.
yes.
Yeah, so that requires treatment, or like that's a congenital thing that we have to accept or something?
So if it is ectopic totally displays on the one side, then definitely we require a treatment, because then vision is not, we are not getting light rays directly reaching to the visual axis. But then polychoria, there is a two pupil, again, yes, we can wait if it is not affecting vision in child, and we can do it at a later stage, because primary it is a cosmetic anomalies. But if it is affecting vision in any of these child, definitely we do it early cosmetic surgery. But most of the time this iris anomalies may associate with the cataract or other lesion, so then we do it combined.
Okay, understood. Okay. So I think now we don't have much any more question. Any final message from your side, sir, before we wind up your session?
Simple, as I told you, the ROPs and the all retina issues. So all child require a first eye checkup to be done between 30 to at least 45 days of life. So it may be term baby or a preterm baby, but then get the eye checkup done. Yeah, that's the final message from my side to all the family practitioners.
Okay. Thank you, sir. Thank you, sir, for giving us the time and enlightening us with so many ophthalmology conditions that can affect the pediatric population. I'm very much now got knowledge after listening to your lecture, that because I'm a radiologist, I'm not aware of those many conditions.
Yeah,
but that was eye-opener for me.
We are seeing a really good cases with you now. As I told you, you are a great help for us in terms of radiology, MRI. I am seeing good pictures coming up from my babies to your side. And that last baby, the advanced ROP also, which requires surgery. So we just did, and there was only vitreous hemorrhage, no detachment. The baby is also doing well. Yeah.
Okay. Thank you for the feedback, sir. So now we'll move on to our next speaker, final speaker for the day, Dr. Priya Pradhan. So Dr. Priya Pradhan, she is our young enthusiastic consultant from Pediatric Cardiology department. She has done training under renowned pediatric cardiologists worldwide. She has done training from New Zealand, Italy, and done fellowships in which she has been trained to do percutaneous interventions like ASD, VSD, or PDA closure. And her interest of area are 3D echocardiogram. And she also has been expertise in doing exercise stress tests, stress echo, tilt table tests, etc. And she's very fun-loving and jolly person, and a health freak, I would say. She's the most active or healthy person in our group, and she's fond of doing trekking and exploring new places. So without much ado, I would like to invite her, and would like to invite her on the stage to share her topic and enlighten us about the pediatric cardiology topic. Dr. Priya, over to you.
So, thank you for the lovely introduction, Hiren. Can you all see my screen and hear me clearly?
Yes.
Yeah. So let's start. So today's topic is modified natural history of congenital heart disease in the current era. So just to give you the gist of how common congenital heart diseases are, I just want to tell you some numbers. So congenital heart disease incidence is around 9 per 1000 new births. So when 1000 babies are born, around 8 to 9 children will have congenital heart disease. Now, out of these children, 25% of them will die in the first year of life if they do not get adequate treatment. So if you see in India, if you extrapolate this number to the population, we are seeing 2.5 lakh new babies with congenital heart disease every year. Now, and then as I say, there are not many centers who can deal with the whole spectrum of congenital heart diseases. Also, there is a lot of fear, anxiety, and people don't seek treatment even if it is available. Cost constraints are there. And so the numbers keep on increasing. So I'm sure all of you in your OPDs will be facing children with congenital heart diseases more and more with coming times. So what I thought to discuss with you today is how things have changed over the time. Now, when we have done our MBBS and from that time to what is happening, pediatric cardiology is still in its infancy. Last 20, 30 years, we have started treating pediatric cardiology as a complete separate entity. And previously adult cardiac surgeons and cardiologists would also do pediatrics, but this is now a different entity, and interventions have started just like 15 to 20 years back, and we are progressing very rapidly. So I just want to tell you what all the scopes are there right now for these children and how their life has changed from previously what we used to think is a very bad prognosis to now how the prognosis has changed and how the life expectancy has changed. So the various diseases we'll discuss, those all the most common diseases that we know. We'll go step by step. Each disease I will tell you what it is. And so the first disease I'm going to discuss is ASD. That's the atrial septal defect. So basically, just to revise, our heart has 4 chambers. The upper 2 chambers are the atria, lower 2 are the ventricles. And in between the 2 atria, the right and the left atria, there is a partition which is called the atrial septum. Now if there's a defect in that, it is called the interatrial septal defect or ASD. Incidence, it's 1 in 1500, 13% of all congenital heart diseases. Females are more affected than males. And most of, so as with all the other congenital anomalies, they occur sporadically, but some of them have some kind of genetic abnormality which can be associated with them. And so they can be seen in clusters like Holter-Arm syndromes. Now, how will the ASD behave? Will depend upon the size of the defect, upon the ventricular compliance, and the vascular resistances. We'll discuss about that later. Let's not go into the details of that. But it's not that every ASD is going to behave the same. Okay. And now what does it cause? Basically, what is the problem because of this defect is that now there is a defect between the left atrium and the right atrium. So when the blood pulmonary venous return comes to the left atrium, it goes to the left ventricle. It has to go to the left ventricle and then to the aorta. But instead of that, some part of the blood goes into the right atrium. Then that part of the blood from the extra blood, which is coming from the left atrium, and the blood which is coming from the SVC and IVC, that is the superior vena cava and inferior vena cava, the deoxygenated blood which comes to the right atrium, all of it gets mixed here. So now there's more blood than what is usually there because of this defect. Now all that blood goes to the right ventricle. Right ventricle and right atrium become volume overloaded. There is much more volume of blood. And all that volume is now going to go to the lungs. So lungs are going to get more volume. So it is going to get volume of the deoxygenated blood plus a part of the oxygenated blood. So what is going to happen is the pressures in the lungs are going to start increasing. So over the time, with increasing pressures for a long period of time, there is going to be vascular disease in the lungs. So what happens in the vascular disease is that the arteries lose its compliance. So when blood comes, they have to dilate. When blood goes, they have to constrict. That goes away. They become stiff. So that is called as pulmonary vaso-occlusive disease. At that point in time, your lungs become very stiff. And that's why the pressure changes don't occur. And then the right ventricular pressure starts increasing more than the left ventricular pressure also. Right atrial pressure starts increasing more than the left atrial pressure. And the blood starts shunting the other way. So that is called as Eisenmenger syndrome. So in Eisenmenger syndrome, the right-sided pressures are more than the left-sided pressures. And that's why deoxygenated blood gets mixed with the oxygenated blood and the patient gets cyanosis. Okay. So because of the ASD, you might get right atrial, right ventricular volume overload. You might get SVTs, that is supraventricular tachycardias. Why that happens is because the right atrium starts becoming big. the SA node, that is the main impulse generating node, is there in the right atrium. So when this tissue gets stretched, the SA node starts triggering, and that you get supraventricular tachycardia or atrial fibrillation, which is very common as the age progresses with ASDs. PVOD is the pulmonary vaso-occlusive disease that we just discussed, and then the regurgitation in the tricuspid valve and the pulmonary valve. So do we have to actually bother and care and get scared about any patient with an ASD? So basically, it's not that bad a disease to have. Most of the patients will be asymptomatic. They might not be even detected. They might even go and become symptomatic in the second decade of life. Or females, as we see that they're more commonly affected with this disorder, they get noticed when they are pregnant, because at that time there is a lot of increased requirement for the heart, the volume increases, and that is when they become symptomatic. So again, congestive cardiac failure is very rare in the first decade. Spontaneous closure is seen if these defects are small. So if they are less than 8 millimeters, they usually get closed. Rarely usually in the first 5 years of life, rarely even up to 16 years, some studies have shown that these defects get closed. But any defect that's more than 8 millimeter usually will not get closed. In fact, some defects also may increase in size. Now, why does that occur? So as the age progresses, the heart grows in size, and that's why it stretches. And that's why the septal defect also might become big. So in a study by McMahon, they had seen that around in 65% of patients, this size also had increased. Now, as we say that this defect is not going to be so symptomatic, but is it going to cause harm to you? So definitely yes. There was a study by Campbell et al. Who has studied various congenital heart diseases and how they have progressed over 25-30 years. It's a long-term study where they have seen that with ASD, 25% patients have died before their 30th birthday. 50%, half of them have died before their 40th birthday, and 75% have died by 60 years of age. And mean age of death was around 40 years. So the conclusion, just to take home, I just want to tell you that if the defect is small, the cardiologist will ask you not to follow up, because we know that there is spontaneous closure is going to happen. If the defect is moderate, like 3 to 5 millimeter around, then we call you after 12 months, because by that time, more than 80% of the defects are going to get closed. So for the first year of life, if as we said, less than 8 millimeter defects, there's increased chance of closure. So by 1 year, 3 to 5 millimeter defects mostly get closed. So we call them for the follow-up. We see whether the defect is there or not. And if it is not there, mostly that happens at 12 months. So we don't keep doing echoes all the time, just we call them after 1 year. Now, but if the defect is a little big, we call them little more later at 15th month. Now, why is that so? The defect is big, but we are calling you later, because even if the defect is large, we need not close it by up to 5 years of age. So in New Zealand, where I was trained, their children used to start to go to school at 5 years. So the advice would be, before he starts going to school or she starts going to school, you come to us and we will get your defect closed. So we wait till that time. Any which ways we are going to wait, even if the defect is large. So might as well wait for some more time, and we call you a little later by 15 months and see whether your defect is getting closed. Now, how do the patients present? So as we said that they are asymptomatic, but as the age progresses, in the first 10 years of life, usually won't be symptomatic, but there is some 2 to 3% of ASDs as well who are symptomatic even in the infancy, that's the first year of life, but that's very few. Grossly asymptomatic, but as the age progresses, you get shortness of breath. As we discussed, the atrial arrhythmia start developing. As the age progresses, the incidence increases. So by 60 years, more than half of them have atrial arrhythmias. Then as the pulmonary vaso-occlusive disease, again, it is seen in 5 to 10% of these patients. Females are have more preponderance, and it is more commonly seen in a sinus venosus type of ASD. So there are different types of ASD: primum ASD, secondum ASD, sinus venosus ASD. Let's not go into the details, but this is a different location of the defect, which gives you the name of the defect. And this kind of ASD has increased chance of pulmonary hypertension and Nissen mingerization. Now, stroke. This again is an indication for closure of a defect. So any person, even so in ACHD, that is adult congenital heart diseases. So even if the patient is 40 or 50 years old, if he has a congenital heart disease, he's still our patient, though we are pediatric cardiologists, because we deal with structural heart diseases. So any patient who has got a stroke usually should, it's a norm that they should get an echo done. Now, why do we do an echo in those patients is to see a PFO or ASD. Because what is going to happen in this kind of defects is that the PFO is a patent foramen ovale. Again, it is the defect in the interatrial septum, which is present in 2% of the normal population. So when we are in the womb, all the babies have PFO. As after birth, you take the first breath, the PFO starts getting closed. But for some patients, it remains patent. Now, what happens is if there is any kind of embolus on the right hand side, like for intravenous drug abusers, or if you've gone deep sea diving and you come back and there's some kind of nitrogen in your bones, all of that comes into the venous system. Now it goes into the right atrium. It will go to the right ventricle and to the lungs. So in the lungs, if there is any gas, it's going to get absorbed. If there is some small embolus, it's going to get stuck in the lungs and it's not going to cause major harm. But if you have a defect in the interatrial septum, this embolus is going to cross from the right side to the left side, from the left side into the left ventricle, into the aorta, and may go into the brain, and it may cause a stroke or any other ischemic events. If it goes to kidneys, renal infarcts, wherever it goes, it may cause an infarct. So in such cases, we electively close the patent foramen ovale. So a patent foramen ovale is a very small defect, which is usually not indicated for closure. As we said, more than 5 millimeter defects have hemodynamic significance. Only those need to be closed. But even if you have a stroke and a PFO, that is an indication for PFO closure. So this again, just to highlight the study, which I wanted to just tell you that though ASD looks like a very simple defect, they had seen quite a bit of morbidity and mortality in these kind of patients. The one which we said 37.5% was the mean age. Again, in pregnancy, what about the mothers who are pregnant with an ASD? It's very commonly seen because, again, as I said, it is asymptomatic in the first decade. Second decade, you ignore, you start presenting only when you're pregnant. And they're usually well tolerated. So we don't ask them to abort, or it's not contraindication for pregnancy. But pulmonary hemorrhage may occur. So when the mother goes into labor, and if she has a prolonged labor, then again, the increased flow, because there's a lot of cardiac output generated, lot of pulmonary blood flow going in because of the defect, it's more blood in the lungs and it may cause pulmonary hemorrhage. And if you have already developed a vascular disease, then the pregnancy is contraindicated. Survival rate, excellent if electively closed by 4 to 5 years of age. 20-year survival. So this is the natural history, what we saw, that if you don't close the ASD, what will happen? But what if you close it on time? So the time of closure, as we said, is 4 to 5 years. If you close the ASD in time, our 20-year survival is excellent. And in spite of that, there's another crux to this, is that the timing of closure is quite crucial here. So if you've closed the ASD very late, then there might be some complications which will not be reversible. So this is a paper which shows long-term outcomes after surgical closure of the ASD. This is a follow-up for around 32 years. What they have seen is, if the ASD was closed when the patient was young, less than 24 years, the pulmonary pressures were less than 40, you had much better results as compared to if you are more than 24 years and you already had increased pulmonary pressures. So you see so much of a difference just by the age of surgery. And this is again a summary of how with age, the complications change. So from 15% to more than 50% because of the age, less than 24 and more than 24 years. So different complications also increase if you close the ASD later. So that's about the ASD. Should we take the questions in the end? But if anybody wants to ask anything in between, please feel free and we can answer them as we go. The second most commonest defect which we come across, which is actually the most commonest defect, congenital heart disease, a cyanotic heart disease, is the VSD. Aortic bicuspid aortic valve is the most commonest. It's 2%, but it doesn't cause that much of anomalies. I will tell you about it when we go to that defect. So VSD for all of us is a most common congenital heart disease. If you have done echoes of newborns, you would see that 5 to 50 out of 1,000 children will have a VSD. So it's that common. But then later on, why don't we see so many VSDs? Is because they spontaneously close. So newborn echoes it's high number, later on when we do echoes, the incidence decreases. Now again, depending upon the position, the location of the defect, and the size of the defect, the whole natural history changes. So every defect is unique. We cannot generalize one VSD and give you a natural history. So as we know that the VSDs are at various positions, if the VSD is near the aortic and tricuspid valve, so this is a picture wherein we have cut the heart at the interventricular septum and we are standing on the right side of the heart. So this is the right atrium and right ventricle which I'm seeing, and left atrium and left ventricle are on the other side which I'm not able to see, and I can see the aorta and pulmonary. So aorta is coming from the left ventricle which I cannot see, it's coming from behind, and pulmonary artery is coming from this side of the ventricle. So the en-face view of the right ventricle is what I'm seeing here. In this view, the PM means the perimembranous VSD, which is situated. I just want you to know about the perimembranous VSD because we have some implications about it later on. So it's just situated quite close to the tricuspid valve and the aortic valve. Most common type of VSD, nearly 80% of the VSDs are perimembranous VSDs. Then these MMM are all muscular VSDs. This is a membranous VSD. This is juxta aortic VSD, juxta tricuspid VSD or inlet VSD. So now again, as we said, natural history depends upon the position, size, number of defects, anatomic vicinity to the aortic valve, age at which it is recognized, association to other malformations, and sex of the patient. So what happens with a large VSD? Large VSD, as the baby is born, the lung pressures are high because the lungs were solid in the womb. There was no air. So once the baby starts breathing, the lungs pressure start decreasing, and by 2 to 4 weeks, up to 6 weeks, the pulmonary pressures normalize. Now, till that time, the right ventricular pressures are more. So again, VSD is the defect in between the left ventricle and the right ventricle. So the left ventricle pressures are the pressures of your blood pressure, nearly like that, you see, because left ventricle has to pump blood to the aorta and then to the body. So the systolic pressure will be same as the aortic systolic pressure. So you and me have 120/80, children will have 90/60. So 90 is the pressure in the left ventricle. Right ventricle pressure is around 20 because it's the lungs pressure. When the pulmonary vascular resistance drops, the normal 20 is the right ventricular pressure. So when a pumping chamber is pumping at a pressure of 90 and another is pumping at 20, the blood has to go from a chamber with higher pressure to the chamber with lower pressure. That's why there is a left to right shunt in the VSD. Now, once the pulmonary vascular resistance is high, there won't be much flow difference because this also pressure is high and the right ventricle is also pumping at a higher pressure. So there won't be much blood flowing. As the pulmonary vascular resistance drops, the right ventricular systolic pressure drops, and then when the chambers are pumping, the left ventricle can pump into the right ventricle easier than to pump into the aorta, because aorta, the pressure, the systemic vascular resistance is the same as your left ventricle. So it's easier to pump in a chamber which has low pressures. So when does the cardiac failure develop? When a lot of blood starts coming into the right ventricle, going into the lungs. So if the VSD is large, it will start very early. If the VSD is small, it may take months to years. Now, another thing with the VSDs, most of the VSDs decrease in size over time. More common in the muscles. So when muscles grow, like how the body muscles grow, the heart muscles also grow, and then they close the VSD. So it's more, perimembranous VSDs also have spontaneous closure, and muscular VSDs, it's more common in the muscular VSDs. Now, some VSDs may develop right ventricular outflow tract obstruction or left ventricular outflow tract obstruction. So these are now the complications which have started coming out. Aortic regurgitation, pulmonary vaso-occlusive disease that we discussed in the ASD, and infectoendocarditis. So all these things come in the natural history of every VSD. So about the spontaneous closure, if you see in utero, if you've done quite a bit of scans, fetal echoes, you'll see that 46% of babies, fetuses had VSD in their echo scan sometime, and they have closed intrauterine. By the time baby reaches 9 months in the mom's womb, nearly half of the VSDs have closed already. Another 25% nearly closed by 1 year of age. 70% of perimembranous and 60% of muscular defects close by around 1 year to 2 years of age. So first 1 to 2 years, most of the VSDs have closed. But still, if the VSD is small, we keep waiting because we know that by 5 years, 80% of small VSDs are going to get closed. Out of the remaining 20%, another 10% may close by 8 years. So see, such a big, vast, spontaneous closure opportunity the VSD gives us. So we can keep waiting and keep watching unless the baby is not having congestive cardiac failure. That means, how do you see if the baby has congestive cardiac failure? Is that if the baby is not feeding well, if the baby is not growing, if the baby has repeated respiratory tract infections, all these morbidities will hamper the growth of the baby, and those things are signifying that the baby is having hemodynamically significant shunt, which is causing harm to the baby, and it has to be closed. Otherwise, if nothing of this is there, but you have a VSD, you can easily wait till 8 years of life. But there is a crux to it that we ask the patients to keep frequent follow-up. Though we don't want to close the VSD, we don't want the patients to lose to follow-up, and I'll tell you why. Because even in a small VSD, there might be complications just because of the position of the VSD. So now this first picture A shows this a perimembranous VSD. So perimembranous VSD is near the tricuspid valve and near the aortic valve. So it might get closed by the tricuspid valve leaflet forming an aneurysm, or it might get closed as in the figure D by the aortic valve leaflet forming an aneurysm. So tricuspid valve leaflet forming an aneurysm is still safe because these are low pressure chambers. The regurgitation is not going to have high quantum even if there develops a regurgitation. So we are going to juggle it so that we want to keep like a good center wherein we don't want to expose the patient to surgery, yet we don't want the patient to have any harm. So we keep watching the VSD very closely. If it is getting closed as in figure A, we are very happy. Okay, tricuspid valve leaflet comes and closes the VSD, and we don't need any intervention, neither a device closure nor a surgical closure. But if the aortic valve starts coming in, what is going to happen is the cusp prolapse causes regurgitation of the aortic valve. Now, this is a very important valve because it's the systemic valve. This valve is going to supply blood to the whole body. It cannot have any regurgitation. Any little, even trivial regurgitation, if the aortic valve develops, we immediately send the patient for surgery. It's like an urgent surgery because we don't want the aortic valve regurgitation to progress. We don't want it to go to the aortic valve repair position, because if the VSD is not closed in time, you might even need to replace the aortic valve. So it becomes a very major consequence. So any valve surgery, I might say, is like a death sentence because there is a lot of complications when you have major aortic or any valve surgery for that matter. There is a lot of implications with medications, lifespan, the quantum of years the valve will last, and so on and so forth. So valve surgery is much more worse than a ventricular septal defect surgery. So any cardiac surgery has an inherent risk, but with advancement in technologies, the risk has got minimal. Even said so, we don't want to expose somebody to any risk at all if naturally it is going to be taken care of. And that's why we really need to know what is the natural history of this disease, because the defect, which might seem to be very big right now, may actually need nothing but just observation, isn't it? So these are the other defects, like the muscular defects, which are getting closed by various mechanisms. So I will not go into details why this pulmonary vasoocclusive disease occurs. We have told how it occurs. It's more common in patients with Down syndrome, and that's why when somebody tells a patient with a large VSD to get operated soon, pulmonary vasoocclusive disease is the most important criteria. So large VSDs usually don't have this aortic valve prolapses or tricuspid valve. These are all in small VSDs. Large VSD, the problem is the quantum of the shunt, the whole big amount of blood going from the left ventricle to the right ventricle. So you're losing blood into the aorta. Aorta is not receiving the blood which it has to receive. So the systemic output is getting decreased. So what happens? How does the baby compensate to that? They have fixed cardiac output. So what they can do is they can increase the cardiac output only by increasing the rate. So there is tachycardia because they have to, suppose you need 2.5 liters of cardiac output in a minute, And because of the VSD, 20 to 30% of blood is getting shunted. So 20 to 30% you have to increase the rate to meet the demand. So what happens is all the calories which the patient is eating are diverted to the cardiac activity. There is nothing spared for growth, and that is why the babies are not growing. So why does failure to thrive occur in VSDs is because of this. Secondly, the increased respiratory infections or respiratory distress is because the lungs are always wet. They are getting so much of blood. That's why you get this subcostal indrawing, tachypnea. Again, the work of breathing causes a lot of calorie, it consumes the calories, and that's why babies don't grow well. So these patients with large VSDs have to repair it within the first 6 months of life. Otherwise, they will have pulmonary vaso-occlusive disease wherein they become inoperable. So that you are decreasing the lifespan of a patient who would have lived otherwise a near normal life expectancy after closure to around 60 years to 20 to 25 years when the patient Eisenmenger arises. So it's very crucial for a large VSD to be closed before 6 months of life. So this is another slide which shows the natural history of infective endocarditis. Again, that's a very common complication of VSD. It's very high in unoperated defects because of the jet. So again, we said that there's pressure difference in between the two chambers. So the blood flows with a jet. So the jet erodes the endothelium of the opposite side of the right ventricle. When the endothelium is eroded, the platelets go and stick. Again, if there is a nidus or any infection, it's going to go and stick and it's going to cause infective endocarditis. Even in post-operative patients, we give infective endocarditis prophylaxis if there is a residual VSD, and otherwise we give it only for the first 6 months of life after intervention, either it's device or surgical intervention. So as we say, small VSDs, even though they might not be hemodynamically significant, yet even after timely closure, the lifespan may be only near normal. They still have higher propensity for certain complications like infective endocarditis, aortic regurgitation, you have atrial fibrillations. These are the complications which occur even after closure of a VSD. But nevertheless, the longevity studies which have been performed, they fairly live a near normal life with normal exercise tolerance if the VSD was closed by time without pulmonary vaso-occlusive disease developing. Now, this is a very good study for natural history. If anybody wants to go and read this paper, it's a beautiful paper. These people have studied nearly 1,300 patients over 25 years, various defects, just they kept on studying them with closure. So they have done whatever is required. So if you have an ASD, you repair the ASD's device closure, surgical closure, and you keep following up the patient for next 25 years. And what they have found also that whatever the size of VSD is, there was very little, but there was some increase, marginal increase in the complications of these patients at the end of 25 years. Now about the PDA. PDA is patent ductus arteriosus. Any questions about the VSD I can take now if you want to. So PDA is
Madam,
yes.
Madam, we'll come to the questions after you finish the presentation.
Sure. Okay. So patent ductus arteriosus is a tube which is present in all the babies when they are in the womb. Again, because there is no lungs, so there is no point in giving blood to the lungs. It's not going to get aerated. So all the aeration is happening in the placenta, and there is a tube which connects the aorta and the pulmonary artery. That is called the patent ductus arteriosus. Now, what happens when the baby is born? Again, the lungs open up because the baby breathes in the air. The pulmonary pressure stops dropping, and this PDA has it is a 3-layered structure. So it has contractile tissue and it starts contracting as the oxygen saturations increase. But in some patients, this remains open. And that's why we call this is a cardiac defect called patent ductus arteriosus. Again, it's a defect between the aorta and pulmonary artery. So high pressure to low pressure, the shunting is always going to be from the aorta to the pulmonary artery. Around 5 to 10% is the incidence, 3% of all the live births. and more commonly seen in preterm. So 1 in 3 preterms and low birth weight babies who are less than 1500 grams will have a patent ductus arteriosus. Now, why is that so? So they do not get time for these 3 layers to develop in the PDA. So the contractile tissue is not yet formed. And that's why they cannot contract the duct since there's no contractile tissue and it remains open in the preterms or low birth weights. Female preponderance 3:1, quite a bit, except for congenital rubella syndrome where the males and females are equal. Now, functional closure is that it is closed, but if you probe it, it can still open. So that is called functional closure. It occurs by around 12 hours. And anatomical closure, that is complete closure, whatever you do, whatever you probe, it's not going to open, occurs so by 3 months. So any PDA, so if somebody says, okay, your baby is 2 months old and he has a PDA and get operated, what would we do? So again, it depends upon the quantum of shunt. So we also do preterm PDA closures if the preterm is ventilator dependent because of the PDA, and if the PDA is causing it causes long term. If you keep the PDA open in a preterm ventilated baby, it causes bronchopulmonary dysplasias. So they might require closure earlier, but whatever said and done, most of the PDAs require closure only around 6 months of age. So in case of pulmonary vaso-occlusive disease, PDA stands first. So first one to have Eisenmenger syndrome is PDA because the pressure difference is vast, iota and PA. Second to cause Eisenmenger is VSD, relatively high but lesser than the aorta and pulmonary artery, RV and LV. And the third is the ASD because there is very less pressure. The LA is around 12 mean pressures, RA is around 7 mean pressures, so not much of pressure difference, not much of blood flowing from one side to another. And that's why the pulmonary vaso-occlusive disease occurs later on. So PDAs need to be treated very early. VSDs comes second and ASDs can be treated by 5 years of age. So again, as we say, I just spoke about all this, that a small PDA usually is asymptomatic only, but the risk of infective endocarditis is more again because of the jet effect, because of the pressure difference. A moderate VSD will cause increase in the LA and LV volume overload and rarely atrial fibrillation because again the left atrium is going to get stretched. It may cause atrial tachycardias. But a large PDA will cause congestive cardiac failure and Eisenmenger syndrome. So if the PDA remains untreated, what happens? See, the risk of attrition is not very high, but it is significant in the first 4 decades. So it's 0.5 up to 20 years. That is 0.5% of the people are going to die. Out of 200, one is going to die by 20 years. 1.5 by third decade, 2.5 by fourth decade. But after fourth decade, 4% every year. So if you leave the PDAs, this I'm talking about is a moderate PDA. Large PDAs will Eisenmenger in the first decade itself, but this is about the moderate PDAs. So closure is very important. Timely closure is very important. It is like the appendicitis for general surgeons, the first surgery that you learn. It's like that for PDA as well. It is not very intense to learn the process of PDA device closure. PDA device closure is it's like a norm now. So unless otherwise, we always do PDA closures with device. Only in very few cases, especially even now the preterm PDA device closures we have started doing. We have attempted in 1.5 kg in our hospital for PDA device closure. So in that small babies also device closures are possible. Only in very few conditions where the shape of the duct is not appropriate or the position of the duct is not appropriate, the patient goes for surgical closure, or otherwise every patient will have PDA device closure. Now, some patients will have echo PDAs. That means the PDA is seen on the echo, but you cannot hear a murmur. So that means it's very hemodynamically insignificant and such PDAs can be left without any treatment. So this is like this is a PDA device. Look how small it looks. This is my palm, and this is it's a relatively big size PDA device that I'm using. And this is we are closing the baby, which is 6 months old. I won't be able to show you the video. So that was all about PDAs. The next one is TAPVC, that's total anomalous pulmonary venous connections. I just wanted to go through this just to show you how the natural history has changed. See, if you had a baby who was having an obstructed TAPVC untreated, only 20% would survive the first year. So 80% are going to die in the first year of life if you're not going to treat them. So what is TAPVC? Is that the veins which are coming to the left atrium. So 4 veins, 2 from each lung, have to come and drain in, get all the purified blood from the lungs and drain into the left atrium. Instead of that, if they drain anywhere else on the right side, so if they drain into the superior vena cava and then the right atrium, it is called supracardiac TAPVC. If they drain into the inferior vena cava and then the right atrium, infracardiac TAPVC. Coronary sinus, if they come and drain, it is called as coronary sinus TAPVCs. So these are anomalous pulmonary venous drainage. What is happening now? All the pure and impure blood, everything is coming into the right atrium. Now, how is left atrium going to receive blood? So it receives blood by right to left shunting from the ASD or PFO. Okay. And obstruction usually occurs at this level. So once the ASD starts becoming small in size, you start getting obstruction and you start getting increase in the pressures in the lung. And this all babies are cyanotic babies. So they will be blue at birth. So if you take saturations of these babies, 4 limb saturations, all the 4 limbs will have less than 90 saturation. And that is when you have to alert yourself and you have to send this baby for further investigations, because TAPVC is quite common. It is nearly 3% of all congenital heart diseases. And the thing is that it can be operated in a single stage surgery. So what we do in the surgery is where all the veins come and combine, we join that part to the left atrium. So we are connecting the left atrium to the pulmonary veins, and then we close the interatrial septal defect. So it's a single stage surgery. In our hospital, the mortality is less than 2%. And in non-obstructed TAPVC, the survival is excellent. In obstructed TAPVC, sometimes what happens is because of prolonged obstruction, the lungs already start getting a little stiff and they might have some pulmonary complications. So this is a developmental anomaly you should understand. The veins have not formed, so there might be some problems in the alveoli as well. So these patients may have some lung issues in their life, but if you see the quality of life of these patients or the exercise tolerance or the longevity, just one surgery and they are good to go. So very important to recognize this early and get this treated early, because the mortality natural history is very bad. Now we come to tetralogy, again the most commonest cyanotic heart disease. This is how I got a paper about a natural history wherein they had done 566 necropsies of patients, and they found that out of the tetralogies, only 2/3 had reached their first birthday, half had reached their third birthday, and 1/4 lived for a decade. So if you had 100 tetralogies, if you see a big child who is blue, then the diagnosis, even if you say tetralogy of Fallows, you will be correct 90% of the times, because no other congenital heart disease is compatible to life as much as tetralogy of Fallow. You can live with the defect for quite a bit of time if the pulmonary stenosis is not very significant. So after the first decade, then the attrition starts increasing. So if you see, 1/4 have lived the first decade. After that, every year, around 6% of children are dying. So 11% are alive at 20 years, only 6% are alive at 30 years, and only 3% are alive at 40 years. So beyond 40 years, a tetralogy of Fallow, however good the physiology is, will not be able to survive without any intervention. Now, this is how the life expectancy of the same paper is just showing how the attrition starts occurring as the age progresses. So how have we modified the natural history of this tetralogy? So phenomenal improvements have occurred after the invention of the Belloc-Taussig shunt. So what is the Belloc-Taussig shunt? Is basically it connects the aorta to the pulmonary artery. Now let me tell you what tetralogy of Fallow physiology is. So basically what is happening here is that the right ventricular outflow tract is obstructed. That means from the right ventricle, blood has to go to the lungs. It is not able to go because of a narrow passage there. Now that narrow passage is caused because of a shift in the conal septum, and that is where the VSD is created. So there is an interventricular septal defect. There is a right ventricular outflow tract obstruction. So what is happening is blood is coming from the pulmonary veins to the left atrium, from the systemic veins to the right atrium. The deoxygenated blood is coming to the right atrium. From the right atrium, it is going to right ventricle. Oxygenated blood from the left atrium is going to the left ventricle. Now, when the right ventricle and left ventricle start pumping, right ventricle cannot pump into the pulmonary artery because there is obstruction, there is stenosis. So what it does is it pumps all that blood through the VSD into the left atrium, and then both the mixed blood, the blue blood, that's deoxygenated and oxygenated blood, both go into the aorta. So the blood which has to go to the lungs to get purified is not going there. So that is why there is cyanosis. Less blood is coming back because less blood is going to the blood, to the lungs. So what these doctors did is they connected the aorta to the pulmonary artery with a shunt. So now what is happening? All the blood which is going to the aorta, part of it is going to the pulmonary artery, and that's how the cyanosis decreased. Then subsequently they developed a port shunt, which is again a central shunt. Then primary repair came. Primary repair means you close the VSD and you open the right ventricular outflow tract. So there are various methods how you can do that, with transannular patch, with a conduit, or by just coring out the muscles. So that we started doing in 1954. So since that time, phenomenal change has occurred, and now after 1975, we have started doing tetralogy repairs in infants. So previously, if we would have been in MBBS, that time they used to say that, okay, after 1 year and after 10 kgs, only a cardiac surgery can be done. So that has changed now. In SRCC, we also do neonatal repairs. That means if a neonate has tetralogy of Fallot and has severe cyanosis, if the antegrade flow, that is the blood flow to the lungs, is very less, we can do a complete repair. We have done a few repairs and the patients are doing excellently well. So complete repair, that is one stage procedure, one surgery, patient is treated for life, unless there are a little bit of tricks which I'll tell you later, where the patients have to come back. So you see how the survival has improved with neonates. So the first natural history curve was like sloping down, but with the recent advancements, the neonates survival is much better. See, the post-operative curve survival is so much better. We have nearly 77% patients living at 30 years. So we had seen that above 40 years, none of the patients live, they had to go through the natural history. And now 2/3 of the patients are actually living a very good life if the surgical correction was done. Now, this is what I wanted to tell you earlier, pulmonary regurgitation. So I told you that the right ventricular outflow tract obstruction has to be taken care of. So how do you do that? Sometimes you have to cut the valve and put a patch across the valve because the valve is too small. So what is happening when you're cutting the valve? The mechanism of the valve is to stop blood from, lets the blood go in only one direction and stops it from coming back. So once you cut the valve, there's going to be leakage. So this pulmonary regurgitation over time can increase to such a degree that the right ventricle starts getting dilated and starts becoming dysfunctional. At that point in time, we have to replace the pulmonary valve. So Hiren comes into play there. We do MRIs and we assess when is the good time to replace the pulmonary valve. Usually after 18 years is the time. And in that point in time, we can also do a transcutaneous pulmonary valve replacement or a surgical pulmonary valve replacement. So in tetralogy, you may need to have a repeat surgery if you have free pulmonary regurgitation. Then we come to aortic stenosis. As I mentioned, bicuspid aortic valve is the most commonest congenital anomaly, but very few bicuspid aortic valves cause aortic stenosis. It's aortic stenosis, basically tightening of the aortic valve, thereby not allowing the blood to go into the aorta from the left ventricle. Now, this is quite a serious issue because if you see the mortality, if you go by the natural history, you have nearly 60% mortality by the age of 40 years. So more than half of the patients cannot even go beyond 40 years of age. And the deaths are unexpected. Why? What happens is when your cardiac output needs to be increased and there is a fixed orifice, the left ventricle can increase the rate and try to pump more blood. But if you don't receive the amount of blood which you require, the brain blood supply gets hampered and there is sudden death. Also, death is seen more commonly after exercise. There's also, even if you have mild stenosis, the risk of infective endocarditis in these patients is high because again of the jet effect. Bicuspid aortic valve, 2% normal births, we discussed all this earlier as well. So what are the treatments? So congenital aortic stenosis again is completely a transcatheter closure, transcatheter intervention. So what we do is we take a balloon from the femoral artery, we go into the descending aorta, from there into the ascending aorta, then we cross the aortic valve and we blow the balloon, and so that we stretch the valve. So if any of the valve leaflet commissures are attached or stuck together, they get torn. So there is a propensity of causing aortic regurgitation, but with the balloon, we try to open up the valve to such a level that there is very minimal regurgitation and the forward flow is better. So we have to again strike a balance in that we don't have to cause regurgitation, but we have to open up the valve. So most cases we do with balloon aortic valvoplasty, but if there is significant regurgitation after the ballooning, or already the valve is leaking, or it is too dysplastic for ballooning, then only the patient goes for surgical aortic repair, wherein they open up the valve or they might have to replace the valve and stuff and so on. The next is coarctation of aorta. Again, this I want to discuss with you just because you people are the doctors who can pick up these disorders, as these are quite silent. So you see this bimodal presentation. If the baby presents very early, they are symptomatic and intervention gets done very early, but sometimes it just goes unnoticed. So how can you pick it? So basically what is coarctation of aorta is a narrowing in the aorta. So what happens is, now the blood, because of the narrowing, the blood cannot pass through the narrowing as smoothly. So there is pressure difference on the two sides. So the upper limbs, the head is receiving blood on normal pressures, which the left ventricle is supplying. But the lower limbs cannot receive that much blood. Okay, so the kidneys, the renal perfusion might get hampered. You might get renal failure. Also what happens is the aorta starts pumping blood at higher and higher pressure because it has to reach the lower limbs. And that's why you get systemic hypertension. So systemic, so if you do BP screenings and if you have high blood pressures, you should go and palpate the bilateral femoral arteries, because bilateral femoral arteries, if they are weak, the pulsations, then you might suspect coarctation. So only one thing, just femoral artery pulsations can pick up this quite a hazardous disease. Okay, because again, the natural history, if you see, 1/4 of them are dying by 20 years, half by 30 years, and 75% by 50 years. So it's quite a high mortality if left untreated. So you might get two types of peaks. Some present as early as in infancy. They have left ventricle goes into dysfunction because it cannot survive the pumping, and some present late with conditions like leg pain because decreased blood supply. You might get hypertension, lightheadedness, disproportionate growth of the upper segment of the body and the lower segment of the body. Epistaxis, again because of high pressure. Dysphagia, if there is a ring, vascular ring with coarctation, then it is near the esophagus. So when the food goes, you might get dysphagia. So what happens with the coarctation eventually is the patients develop congestive cardiac failure because the left ventricle starts failing. The rupture or dissection of the aorta where the coarctation is, the post-coarcted segment may get dilated and there might be a rupture there, or at the point of coarctation, infective endocarditis and cerebral hemorrhage because of hypertension. So hypertension is basically the chief responsible for morbidity and mortality with advancing age. Again, for the treatment, we have various options. We can pass balloon across the coarctation and expand it. Now, this procedure we do when the patient cannot go for surgery. It's so sick that anesthesia cannot be given. So this is like a temporizing procedure in small babies, because only with balloon, the coarctation will reappear. So you're going to expand it, and in 20% of the patients, it recurs. So it might need another intervention. So instead of that, if the patient is healthy and can withstand anesthesia, then we send him directly for surgery. Then stenting of the segment can be done in adults. So we just go at the coarcted segment with a stent and you expand it with a stent. Again, all the procedures have very low mortality and the results are good. But again, If the procedure is not done in time, then the hypertension may not always recur. So this is one of the procedures where we had done ballooning for a very small child, if you can notice. So this child was less than 2 kgs, and we could not have the femoral, because the femoral artery is so small, we could not even pass the sheath through it. So we have gone through the carotid, which is a bigger artery, and we are doing angiograms, and I'm showing you that how the coarctation is there. So if you can see, notice there the narrowing in the aortic arch. Then we have passed the balloon there. Can you see the balloon expanding against the segment, and this waste is now disappearing. So there was a waste initially, and now it is disappeared. We'll see it again. And then now you can see that the coarctation is relieved. So if you see, this blue flow is laminar. There is no obstruction there. And this was the baby, a tiny less than 2 kg baby, where we could do balloon coarctoplasty to relieve the left ventricular dysfunction and congestive cardiac failure. Now, another very common congenital anomalies easily treated is congenital pulmonary stenosis. So it's just predominantly valvous stenosis. That is, the valve of the pulmonary artery is small, and that's why adequate blood cannot reach the pulmonary arteries. The right ventricle gets more and more blood. It gets pressure overloaded because it has to pump with high pressure, and then it starts failing. So again, relatively common, 10% of all congenital anomalies. It's seen that in 69 cases with 50-year follow-up, average age of death was 26 years, 7 patients survived up to 50 years, and 3 survived up to 70 to 75 years. So longevity depends upon 3 variables. First is the initial severity of stenosis. Second, if it was constant or it is progressive, and how much load is it giving to the right ventricle. So if the right ventricle starts failing, then the prognosis is very bad. Presentation again, dyspnea, fatigue, giddiness, lightheadedness. If the right ventricular hypertrophy is too much, then you might, occasional chest pain might come because of the ischemia, and there might be sudden death because of the right ventricular infarction or coronary artery abnormality. And you also might have the aneurysm of the post. So what happens is, even in the aorta coarctation, I showed you that the post-stenotic segment is dilated. Same happens with the pulmonary artery. Post-stenotic dilatation might get ruptured because of the thinning. Again, the treatment here is in predominantly valvous stenosis, 99% of the patients get treated by balloon pulmonary valvotomy. That is, again, you go pass a balloon through the femoral vein. Femoral vein, we go then go to the inferior vena cava, right atrium, right ventricle, and right ventricle to the pulmonary artery. So you cross the pulmonary valve and you inflate the balloon and you get rid of the stenosis. So see, these procedures are so simple. The patient gets admitted the previous day, procedure happens the next day, third day baby gets discharged. There is no blood loss. You do not require general anesthesia, only sedation is required. There is no stitches required. And big, very difficult, very morbid congenital anomalies get treated with these kind of procedures. So it's quite a good advancement that we have made, and we have really changed the course of these diseases. Actually, if you see, the epidemiology also has changed because of fetal diagnosis. So you don't see hypoplastic left heart syndrome because that's the most morbid pathology anybody could have. So these babies are getting aborted because of the diagnosis, early diagnosis. At 20 weeks anomaly scan, they get diagnosed and the babies get aborted. So the whole epidemiology of congenital heart disease is going to change because more and more severe congenital heart disease patients are going to get aborted, and only the simple heart diseases will live and they will have better outcomes. So another case is Epstein's anomaly. Epstein's anomaly is basically displacement of the tricuspid valve. Do we have enough time, or we can, Hiren? Should we skip through these slides faster? So Epstein's anomaly is basically displacement of the tricuspid valve towards the right ventricle. So the basic right ventricle cavity becomes very small, and the blood now cannot go into the right ventricle very easily because the cavity is small, the compliance, it cannot relax when it has to take the blood. And so the blood goes from the right atrium through the PFO or ASD to the left atrium. So these patients also may have cyanosis at birth. So in neonates, if you see, so Epstein's anomaly, again, it is, if you have Epstein's anomaly detected in neonates, it's very bad prognosis. But if you have Epstein's anomaly detected later on, which are a little less severe Epstein's, then the life survival is quite better. So if in neonates you detect Epstein's anomaly, 20 to 40% of the babies do not survive the first month of life. See, it's so bad. And less than 50% survive to 5 years. But if you detect it in adulthood, the prognosis is quite good, only that there might be paradoxical embolus, as we discussed, brain abscesses and sudden death. Here the treatment is cone repair. So what the surgeons do is, the anterior tricuspid leaflet is quite big in these patients. So they roll it out and make a cone out of the anterior tricuspid leaflet, and they lift it up so that the right ventricular cavity increases. This operation is very difficult, but in good hands, it gives very good results. If you see the survival rates, so this is a Selimages study wherein they did 220 post-op cases and they followed them for 1 to 34 years. So long-term follow-up we have. And the survival was 67% at 1 year, 59% at 10 years. Now, in spite of the best treatment, why are these patients still dying? Because if the presentation was severe initially, or you have detected it in the fetal echo, or you have a right ventricular tract obstruction, then the mortality is higher. And these patients get arrhythmias because of the dilated right atrium. Again, the incidence of arrhythmias is very high, and they might also get heart blocks. This is the second last slide, actually, detransposition of great arteries. Again, I want to just tell you, very severe kind of congenital anomaly, there is definite mortality by 1 year, 80% mortality by 1 year. What is happening in this case is, instead of the aorta coming from the left ventricle, pulmonary artery is coming from the left ventricle. And instead of the pulmonary artery coming from the right ventricle and taking all the deoxygenated blood to the lungs, it's aorta is coming. So just imagine, all the bad blood is going back to the body, all the good blood is going back to the lungs. So this is definite mortality immediately in the post neonatal age, like when the baby is born, unless you have somewhere some mixing like PD or ASD. So then these patients might survive a little longer. Then as the PDA closes, again the baby might die. But if the PDA remains patent, it might live a few more days. Now, if there is associated VSD or no VSD, again the natural history changes, and associated pulmonary stenosis is present or absent, the natural history changes. But I want to just focus today is that this arterial switch operation, which is done in our hospital, very nicely done, because it's a very difficult operation. In this, what they do actually is they switch the arteries. So now the aorta was coming from the right ventricle, you take it back to the left ventricle, and pulmonary artery to the right ventricle. But by doing so, you also need to switch the coronaries. You understand? So the coronaries switching is quite an intensive procedure and very skillful procedure. So that is why the arterial switch operations are not done regularly in many centers. But in our center, we have even done late switches, like even at 1 year of age, when the prognosis really becomes very bad, we have done switches. We have sent patients on electively ECMO patients. So what we do is we do the switch operation, and because the left ventricle now was only pumping blood to the lungs, it has lost its vigor, because if you're doing less work for a long time, you suddenly cannot take more work. So you have to train it. So what we do is we electively keep the patient on ECMO, that is extracorporeal membrane oxygenator. It's like a bypass machine, and you make the left ventricle better and better with time. So for a few days, elective ECMO, and then the patients are put back on. We stop the ECMO and then natural circulation starts, and we have got very good results with the arterial switch operation. So these operations need to be done within the first week of life. And sometimes if you cannot reach the center, then there are some certain other options like balloon atrial septostomy, which can be done bedside to temporize the patient by the time it reaches the hospital. Otherwise, if there is no mixing at any level, the patient has no chances of survival. Last slide is the single ventricle physiology. So any type of single ventricle wherein you don't have two pumping chambers but one pumping chamber. Now that can be because of one valve not being there, like tricuspid atresia. There is no tricuspid valve. So blood from the right atrium, from the ASD, blood cannot go to the right ventricle because there's no tricuspid valve, so it has to go somewhere. So ASD is always present in these patients. So from right atrium, it goes to left atrium to left ventricle. There will be always a VSD because blood has to go to the right ventricle and to the pulmonary artery. So ASD and VSD communicates, and so these are patients with single pump. So they don't have two pumps because either they don't have a valve or the VSD is very large that the two chambers are acting like a one chamber. So in this single ventricle physiology, you can either have various diseases with increased pulmonary blood flow or decreased pulmonary blood flow. Again, the natural history depends upon that. The patients with increased pulmonary blood flow will have morbidity and mortality because of pulmonary hypertension, and with decreased pulmonary blood flow because of cyanosis and its complications. So any single ventricle grossly, we say, would not cross 10 years of life. Very few conditions where the physiology is better, with like tricuspid atresia with minimal pulmonary stenosis, might live maximum to 20. But now with the kind of treatments we are offering them, we offer them stage surgeries. So if you have increased pulmonary blood flow in the first stage, we do a pulmonary artery banding so that the pulmonary blood flow, the blood flow to the lungs is controlled, so that the lung pressures remain normal. Then in the second stage, we connect the superior vena cava to the pulmonary artery because the pulmonary blood flow has to be maintained. So we connect, instead of going to the heart, because there is no two ventricles, the right ventricle is absent. So blood can directly go to the lungs because that is where it has to finally go from the heart. So blood from the superior vena cava goes to the lungs. The third stage, the blood from the inferior vena cava goes to the lungs. So this is called Fontan completion. So in this category, the patients become normal oxygen saturation when the Fontan completion occurs, because now we have separated the circulations. All the blood, systemic venous return, is going to the lungs, getting purified, coming to the heart, and from the heart is going to the body. So the patients have 100% saturation, even though they have a single ventricle physiology. So single ventricle physiology is a cyanotic heart disease, but with a stage surgery, we can convert the cyanotic heart disease to normal saturations, and we can increase the life expectancy. In New Zealand, I had seen an architect, 55-year-old with Fontan, walking around doing all the activities. They used to be very active. They used to come by cycle to the hospital, and he was doing all of that. So this is what the advancement in medicine is. A person who would not cross his 20 years is at 55 living healthy, hearty life. This is how we have changed the natural history of the congenital heart diseases. There are many more diseases to discuss, but I've just picked up commonly seen ones to give you a rough idea about what's happening all over the world. Yeah. I'm open to taking questions or suggestions.
Madam, thank you very much. It was very exhaustive, but you have actually covered the whole of pediatric cardiology with all the abnormalities. Thank you so much. And I must praise you because at such a young age, you have done so many things and seen so many things in your life. I think if I have a pediatric patient having some cardiology problem, I'm going to refer that child to you only.
Thank you so much.
Madam, I have a few questions for you. I'm Dr. Anil Hardasmalani. Madam,
Sure.
most of the cases you said when it comes to AST or whether it is a VST, every time we are basically worried about the Eisenmengerization of the patient.
Yes.
And that is where the problems are actually occurring. Now, I have a child who is about 5 years old with 7 mm of VST, and there's no Eisenmengerization. And every year we subject him to an echo and we see whether his the VST is worsening or the pressures in both the chambers are worsening and whether he is having any symptoms. Now, what should I do with the child? Because in the last 3 years, from 5 to 7 years, 5th, 6th, and 7th, 3 years of echo and supervision, he has not shown any progression. Now 7 years means it's quite a time now. Should I go for the closure or still should I wait? As in exceptional cases, you said up to 16 years also it will close.
So again, 7 mm hole is not a small hole. Okay, so there will be definitely left atrium and left ventricular enlargement. So if you see the dimensions in echocardiography, the study for volume of the ventricle. So if the left ventricular volume is more than 2 standard deviations, that is the left ventricle is becoming big. So it's like a rubber band. If you can stretch it to a particular limit, it will remodel after the defect is closed. It will come back to its original position. But beyond the point, if you keep stretching it, it is not going to come back to a normal position. One. So second, again, the position of the VSD. So I would close the VSD for three reasons. If I do the echo and I see that there is left ventricular enlargement, so the left ventricular dimensions are more than +3 Z scores, I would like to close the VSD. Second, the patient has started developing pulmonary hypertension. 7 millimeter VSD will have some amount of pulmonary hypertension for sure. Third, the position of the VSD. If it is anything like a subarterial VSD, it is not going to have spontaneous closure at all. Secondly, mal-aligned VSDs have no spontaneous closure. So those kind of VSDs, there is no point in waiting. And we have got device closures options available for VSDs, which again, as we said, it's a very unique procedure in which there is sutureless closure of the defect. So we have to weigh the pros and cons, and we have to actually go closely and examine the patient regarding his other things like failure to thrive is there, and other things like if there is any increased respiratory illnesses, all that comorbidities put together. 7 millimeters is a significant defect, so you should not be waiting and watching it. If it is not changed much in the last 3 years, it is not going to change from here on. And so if the position of the VSD is not favorable, we should go ahead and close it. For the fear of one, left ventricular enlargement will stop. Second, pulmonary hypertension will stop. And third, infective endocarditis risk decreases drastically.
Madam, had the child been say 3 years old and the defect would have been say 5 mm, then what would you have done?
So again, the same thing. See, it depends upon the size. Size is one thing which we see. We have to see how much hemodynamically significant the defect is. Where is the defect? What proximity structures are there? If it is near the aortic valve, causing aortic valve prolapse, causing aortic regurgitation, may cause aortic regurgitation, I will not wait even for a 2 millimeter or 1
I'll call you back. Yeah, madam, I got it. The fact that you said that we are
capillary size defect also. So now I was just in Sangli for a diagnostic camp. So there we see like 200, 300 patients in the span of 2 days. We screen them and we tell them if they require any intervention. So in that case, there I saw a capillary size defect, hardly any blood going from the left to right, but already the aortic valve has come and closed it nearly, and there is regurgitation of the aortic valve. Now this patient will come to me saying, I'm not symptomatic, there is nothing, you cannot even hear a good murmur, but this patient, I will say early VSD device, surgical closure, just because I want to save the aortic valve. So a lot of things come into play when we make decisions about the closure of VSD, not only the size.
I got it. Everything has to be taken into one and seen as a whole instead of just going into the size or just going into the symptoms. That's really very enlightening. And one thing is there, the moment we diagnose some child with a congenital defect, I think the best judge is the pediatric cardiologist. It should not be left in the hands of anybody else.
I think
even an adult cardiologist will not be able to give the guidance the way you all have seen the cases.
So I really thank you for that thought, because it's coming from you. See, what even I observe is with fetal echoes as well, the person who is doing the fetal echo will be a radiologist, will be a gynecologist, and they have diagnosed that fetal anomaly, okay? But they do not know the natural history or the natural history of those ailments, because it's so rapidly progressing. It is beyond any capacity to keep in touch. Every day new guidelines are coming, new studies are coming, new evidence based strategies are coming to deal with the defects. And that's why I think the best thing is to do is to refer those patients to the respective specialist in any field for that matter, because things have been rapidly changing, and you have to give the best to your patients. Then you have to actually let the people who have gone somewhere trained in that faculty spend so much time and energies do the job, you know.
And that's very true. I appreciate that. And I really, today out of my heart, I feel that even though we have learned so much in cardiology and we have seen so many things in ICU, still every specialty has its own charm and every specialty needs its own master. You cannot be a master of all. So let the masters do their own specialty work. I appreciate that. Thank you so much, madam.
We need you all to pick those patients and send them to us early, because as you saw, the time is quite crucial in any congenital heart disease, So be aware. So if
That's
you're
true,
not
madam.
aware, you won't pick. So being aware is very important. There is where you will pick diseases. Simple things like forelimb saturations, upper limb, lower limb blood pressures, all those things, palpating femoral pulses, all those things will give us a good number of patients who would otherwise be missed and left untreated.
That's true, madam. For as far as cooptation of aortas are concerned, we are definitely looking into them because they are the ones who actually we can pick up. But as far as pediatrics are concerned, only the moment we hear a murmur or something, or we find that the child is definitely showing edema feet and maybe the
So that's another
CVP high or something. The moment we see hepatomegaly, pedal edema, congestive cardiac failure, we know it's a case that I have to refer to the pediatric.
definitely, yeah.
Thanks, Dr. Anil, for very active interest for all the talks. I can see he's actively attending all the talks and questioning every speaker. That's really nice for him.
Sir, thank you so much for your compliment.
Dr. Priya, so moving on to the next question. Sudharma Dalvi, she has question related to valve. She is asking that what will be the ideal age for valve replacement? Do you want to enlighten something regarding that prosthetic valves?
Yes, sure. So, valve replacement would usually in pediatrics is a last resort surgery. What we try to do more commonly is try to repair the valves. Why? I'll just tell you why. See, replacing a valve, we have two options. Either we have a bioprosthetic valve or a metallic valve. Now, in pediatrics, the main constraint is the size. The babies are so small that if you replace, even if you get a valve of that size, the baby is going to outgrow that valve. So you're going to require multiple surgeries in the same lifespan. So only not because the valve has turned bad, but because the baby has outgrown the valve. Okay. So the first thing we do is valve replacement. Now there is no repair, sorry, not replacement. So there is no particular age at which we have to, even in neonates, if they have very bad valves, they are regurgitating, they are stenotic, they are dysplastic, they need to be taken care of. Now, in those age groups, we always first try to do repairs. Now, if the repairs are not successful, then even in neonates and small babies, we have done prosthetic valve replacement. So in those cases, what we do is there are various different valves available, but they are not available for this age group. So they are modified. Like you take a valve for some other indication because the size is small and you put the valve in the particular child. Now, as I said, the valve needs replacement. Usually we use bioprosthetic valves in children or metallic valves, depends upon where the child is coming from, because metallic valves need intense anticoagulation. So they need to take warfarin, they need to monitor the INR. So if the patients are from very remote areas and they will not be able to do all this, then the valve gets stuck. So if you're not on blood thinners, if the adequate INR is not maintained, then the valve leaflet stop moving, it gets stuck, and that's the end of it. So anticoagulation is very important. In females, if you're on warfarin, then during pregnancy, there are a lot of complications. So it depends upon the sex also. So in females, we prefer bioprosthetic valves. The problem with bioprosthetic valves is that the lifespan is small. So they will last 10 years, 12 years, even like in a full grown child, if you have put the valve, and we have to keep changing the valves. But a metallic valve will last the lifetime. Like the patient will die and the valve will still be there if the anticoagulation is well maintained. So selection of the valve and the age at which it has to be changed depends upon the etiology and the pathogenesis. And it is not, we don't have any contraindications for that. But we always try to be conservative. So that is the one thing. Even if you have severe mitral regurgitation, severe aortic regurgitation, if the patient is not symptomatic, we try to conserve them with medical management. We want them to grow. We want to wait till a time comes where there is no other resort but to go ahead with the surgery. And in the surgery, always try repair first. If it fails, then replacement.
Thank you. I can say that with my experience of last 2 years, that our pediatric cardiac team, including all cardiologists and surgery, they are doing very complex and very difficult cases with very great successful outcome since they send us for CT and all. So we know that how complex cases are being referred to SRCC, and the way they are handling is like commendable. Thank you, Dr. Priya, for that also.
Doctor, can I just ask Dr. Priya one small question? What is happening in the field of cardiac transplant in the pediatric age group? Do we have that available and a little know-how about it?
Sure. So, pediatric cardiac transplants are available. Currently, we haven't done any in our center, but we have now got equipped with everything that is required for cardiac transplants, and soon we're going to start a proper cardiac transplant program. Said so, in Mumbai city, we have active programs wherein cardiac transplantations in pediatric patients are being done. Now, the constraints, again, as always in pediatrics, is the size. So a baby 7 years old needs a cardiac transplant for whatever etiology, may it be a myocarditis-induced cardiomyopathy or a congenital cardiomyopathy, whichever type of cardiomyopathy or whatever, any tumor, mass, anything, they will benefit from cardiac transplantation. But the limiting factor is the size of the heart. So you cannot put an adult-sized heart in a pediatric patient. And to get a brain-dead child of that around that age is a difficult thing, but otherwise the whole process goes as the adult transplantation. The rejection rates in children are comparable to the adults. Everything is nearly comparable to the adults, and longevity and around 20 years is what they say for pediatric cardiac transplant. After that, you might require another heart or some other technique to change the existing replaced heart.
Do we have availability?
Pardon me?
Do we have the availability of ventricular assist devices in pediatric age group?
Not yet. No. So we don't have the full-fledged like LVADs what we have in adults. We don't have those sizes in pediatrics. Again, everything size is a constraint. But there are other devices which we can use like the LVADs. Not as good, of course. So some pumps and stuff like that can be used to temporize. But cardiac transplants is definitely available in pediatrics. It's a disease.
Thank you so much.
You have to weigh the pros and cons. See, the patient has to be on therapy lifelong. Get cardiac biopsies every month for seeing for the rejection. So it's an intensive program. Just getting a new heart is not. It's the disease.
I understand.
It actually starts from there. I was actually we have 2 minutes here. Like in Chennai, when I was working, we had this one child with a atrial myxoma. That's a tumor in the heart. So the surgeons went and they tried to remove the tumor. But when they went in the operation theater for removing the tumor, they needed to cut quite a bit of muscle. And then when they sent a part of the tissue for frozen section. So frozen section is basically the pathologist sits in the operation theater and he puts whatever tissue you're giving on the slide and sees whether that is cancerous lesion or not cancerous lesion. Because if it is cancerous, you have to completely remove it. If it is benign, then you can keep a part of it if the function is going to get hampered. So the frozen section came as cancer. So they had to like completely clear it off. And by the time they realized now the whatever is remaining is not going to be functional heart. So then they activated the cardiac transplant team. Now this boy was a 7-year-old boy and he needed a heart. And in Chennai, when the cardiac transplant team got activated, within 6 hours, he got a heart. A 12-year-old boy we in other city had was brain dead, was on ventilator, and they got the heart available. And within 6 hours, this patient got a new heart, like without any problems. And that was... So even in India, we have these kind of success stories, and we presented this paper in the Asia Pacific, and it was very well appreciated. So it's happening.
Madam, that was lovely actually. But as far as I have read in the books, atrial myxomas are usually benign tumors.
Yeah, so
this must be one of the rarest. Yeah.
Went with the thought of that it is going to be an atrial myxoma, but it was a precancerous lesion. It was not an atrial myxoma.
I see. It wasn't an atrial myxoma.
You just go with the thought, okay, maybe it's that. But when we started doing the frozen, we realized that it is not atrial myxoma.
I got it. Thanks for the case.
There is one question which has come up, like maximum how many times repeat heart transplantation can be done?
So see, internationally they have gone up to 3 as well. So if sometimes the heart gets rejected immediately, like there are categories of rejection, and some patients idiopathic rejections also occur. So you never know why it got rejected, but in the first place. But some things are quite predictable. So it depends upon that. People have gone up to 3 internationally, but I'm not sure in India how much we have, even if we have done a repeat heart transplant at all.
Okay. Any more questions? Anybody? If there are no questions, then I think we can wind up today's session. And I think we can see by the chat box and everybody's response that everybody loved today's all the topics. And they came to know that SRCC hospital is doing such a nice high-end work with this kind of consultants and with this kind of high-end facilities available. So with that, I would like to announce the next month's the masterclass, and the topics are, I'll just read it for you guys. So the next month, the first topic will be covered by a pediatric neurosurgeon, that is Dr. Sumit Pawar. He will be talking on the spina bifida and the spinal dystrophism related topics, which is also very common conditions, and people don't know much about what to do in this kind of back swelling and those kind of thing. Second, I myself will be taking a short session on imaging approach to pediatric neck lesions, and when to do USG, when to do CT, MRI, and how to diagnose those conditions, those kind of things. And the third lecture will be taken by Dr. Vaishali More. She is a pediatric nephrologist, and she will take a lecture on approach to renal stones in children. So that will be on the next month. It will be on the 18th August 2021. And I would like to invite you for that also, as you have attended today's lecture. And you can write down any queries to our email ID if anything you have some later questions to any of our consultant. And thank you for attending us. Dr. Priya, you want to say any final words for them?
No.
And happy to all, and enjoy your rest of the day.
Thank you all for your patient ears, and keep referring.
Yep. Okay. We can wind up this session. Thank you.